very good afternoon to all of you. I'm Dr. Beamish, third year postgraduate from the Department of Gynecology and Obstetrics, SKIMS, and I'll be hosting the academic session of Continuing Medical Education Program organized today by the Department of Hospital Administration. This program will be broadly divided into 3 sessions, each chaired by the group of experts. As we all know that with the quantitative grant, in our hospital, the doctors are not able to connect with patients quite often. We need appropriate application of scientific and psychosocial knowledge to understand each individual who seeks medical care. This in turn requires the ability to communicate effectively with each patient. Our first session is based on the same issue, which is clinical approach to patients and our pitfalls and doctor-patient relationship. And for this, I would like to call upon stage the chairpersons for the first scientific session, Professor Nisar Ahmed Rambu, Head of the Department of Cardiology, SKIMS. I would request now Professor Abida Ahmed, in charge of the Department of Gynecology and Obstetrics, to come on with the scientific.
Without wasting time, may I call Dr. Ejaz Nabipour. He will be working on clinical approach to patients and the common pitfalls. Dr. Ejaz Nabipour.
With the permission from chairpersons, Assalamu alaikum and a very good morning to all of you. At the outset, I want to pay tribute to those residents who are not present in this auditorium this time. They must be discharging their duties either in casualty, either in OT, either in OPDs. I am thankful to the organizers to giving me a chance to be one-to-one with my residents again. And my aim of presentation is to take you from 19th century to 20th century and hoping how we should land up in 21st century. Lofty mountains, B-line of very good buildings, pine forests. This is the Davos, Switzerland. But what I am talking about? Davos, Switzerland is important about the economic summit, which is going every January, every year, which makes a roadmap for the economic survey worldwide. And today is the concluding day of this economic summit at Davos. One line which caught my eye yesterday once I was making my presentation. There was one forum which tries to give a slogan worldwide for 21st century: man, machine to be replacing man. I did not swallow this word wholeheartedly. But at the same time, I thought, am I underestimating the worldwide skills which are at forefront to transform machines into realities? Why I am saying so? If Emperor Akbar was told that there will be a metallic house which will fly in the air, he would have imprisoned us. But it is a fact today. Aeroplanes do travel. That made me to put into my mind a forecast for 21st century. I am expected to talk on artificial respiration, but what is this artificial intelligence? Artificial intelligence is a symbolization coming up these days in the world, where machines are going to perform complex tasks. Those tasks which are very likely to be performed by men, by human beings. And what are these tasks? Of learning, of problem solving, skills. And we have got multiple examples of these coming up during last 2 to 3 decades. The roads in the Europe are going to see these self-driven cars this year. You have robotics. You know much better than me about robotics and its role in surgery. Drones. In most of the wars, drones were used. So are machines taking over man? And should we be prepared for it? The history of artificial intelligence started in the 1940s, once the theory of computation started. And in the last 70 years, man has made a tremendous advent bigger than Alps. And it has found its role in neurology, in cybernetics, in informatics. And what is the concept today? Human being is trying to make an electronic brain. And if an electronic brain is made, it will perform the complex tasks which we are supposed to be doing. And it will have all the components. Reasoning, knowledge, planning, which our prefrontal cortex and frontal lobe has. Learning, processing, manipulation. Everybody must have seen the Hollywood movie, Good, Bad and Ugly. So, gimmicks of all sorts together. So what will be the response? The lower panel, these will be the faces. If a patient comes to the casualty and he will see one of the electronic brains like a lower panel, how bad he will feel? I don't know. That's why I have kept a question about emotions. Will these machines have emotions? I really don't know. But there has been application of artificial intelligence. Anatoly Karpov and Garry Kasparov were the wizards of chess, the times we used to also play. And the Deep Blue was a computer. This computer was made just to give resistance to Garry Kasparov's advent. And he begged him in 1997. AlphaGo super module is made in 2016, which is almost a supercomputer. A Hanover machine was made by Microsoft. What is the work of this machine? If somebody has acute lymphoid leukemia, somebody has chronic myeloid leukemia, you have various regimes of giving treatments. This machine gives an advisory to the patient and his attendants which protocol of therapy you should take. And in Washington they found that robots are stitching better than human beings. So should we be scared of these machines? Or we should still rely on our emotions? I have been taught that medical science has a triad, which our worthy director was also mentioning about. The prime aim is treating. Treating who? Patients? Don't use this word. You treat sick. You treat who needs help. There comes the emotion part. The machine can make him a patient, but a human being, a doctor, a paramedic, will not make him a patient. He will see him as a sick. And teaching who? A postgraduate? Why are you labeling him a postgraduate? Aspirant, who wants to absorb this as a blotting paper, and then who wants to treat. That should be his aim. Trodding new heights for research. And what is the aim of it? To teach. And then what is the aim of the teach? To treat. And this complex performance can be done by human beings. Can it be done by machines? Maybe it may. I don't know 200 years from now what will happen. Once I was in third year, we had Robin's pathology. And something was written on its front page which always has been haunting my mind. That don't come so near the tree that you lose the sight of forest. Has human being cross that line which nature had put it. Research is okay, advancement is okay, computation is okay, cloning is okay, but are we transgressing the limits of nature? Or I, as a person who is not digesting that we will have machines? The decision lies with the audience. I want to tell you about two studies. The Royal College of General Physicians in 2003 in Berkeley's group gave to the United Government that 10-minute contact time should be between the doctor and the patient. What is this time 10 minutes for? An expert consultant can make a diagnosis in 2 to 3 minutes for around 70 to 80% of diseases. But this is compassion. This is his contact with him. And from a resident point of view, the Royal College of Physicians Working Group in 2009 gave a representation to the House of Commons in UK. They had a working hours of 60 hours for residents, that they should bring down it to 44 hours. What was the reason? There was a burnout among residents. Are we forgetting these things in 21st century? I believe that we should have 4 things to have a contact with patients. First of all, we should perceive. Perceive he is in need for us. That's very important. And then you should be a historian. You will ask him, what is his problems? This you will not change. Then you will be an interrogator. You will put him a set of questions, a systemic review, to come to a conclusion what could be his problem. And last of all, you need a human mind to analyze it. We have left these things in 19th century. 20th century saw a change, which I will tell you in my further slides. And 21st century, I think we have to catch hold of these again. Why? I will tell you in my further slides. And what are the pitfalls of these 4 things which I have told you? Why are these 4 things, perception, interrogation, historian and analysis, going out of our lives as healthcare workers? Because the number of patients is swelling up. Working hours have become extended. The residents work 40 to 60 hours, which is not probably recommended. The consumer is becoming more demanding. That's your sick patient, his family. You have got multiple preoccupations, from Facebook to WhatsApp. You have high-tech lifestyles. And after all, administrative apathy is worldwide. It is an international phenomenon. They don't give care to what the resident staff is lacking. So what happens? The strikes. Will the struggle continue in 21st century also? But at the same time, there is a word of caution for my residents also. The word of caution is that we have been labeled as poor historians, and history is the basis of our encounter with the patient. If you see the internal medicine residency program, a review comes from Illinois every year, how the residents feel about the system and how the system feels about the residents. The word which has been mentioned that they are poor historians. They don't give good time to the patient. I have read John Patton's Clinical Neurology during my post-graduation days. In his acknowledgement, John Patton mentions, if a resident writes in his notes that the patient is not cooperative, you should question the wisdom of the resident, not the uncooperation of the patient. After taking history, your clinical skills come into being. I advise you to believe your eyes, ears and fingers. Not that somebody has labeled somebody as a diabetic cardiomyopathy and you will go on writing on case of diabetic cardiomyopathy. Somebody has a stage 4 astrocytoma brain and you will go on. No. You are responsible for what exact words you mention yourself. And there's always the question. You can question anybody. Even a consultant makes a diagnosis. You have a full right to make a query to it. You should have a power of observation. Correlate clinical findings with academic know-how. And hands-on training is more important than sitting in the hostel and going through the notes. Sheila Sherlock is a doyen of hepatology. She writes in her book that a half-hearted examination cheats the patient as well as the doctor. Patient for his diagnosis and doctor for his honor. Clinical specialties are not only need to have clinical skills, have paraclinical specialties, radiology, pathology, microbiology. They should have an integration of the basic knowledge with the specialty they are in. Non-clinical subjects, paramedics, nurses, but what for they all need these clinical skills? I have gone through an editorial in Lancet 2008, volume 47. In Sicily, one person gets a cardiac arrest and he falls, drops in front of a line of shopkeepers. There were many shops. He gets a chest pain, he drops down. And they call a paramedic van to take him, but the patient died. They were served and noticed by the Surgeon General of Sicily that why did not they attempt CPR on that patient. If general public can be made accountable for not helping a patient who needs your help, what about us? So CPRs, resuscitations, helping hands should not only be left to clinical specialties. Each and every person who works in a healthcare status should be kept responsible for lending a helping hand. A quick view of an index case of all the specialties helping each other. I had a patient who had a mediastinal lymphadenopathy. We did a biopsy through bronchoscope. It came out to be one of the pathologists mentioned as sarcoidosis. We had some doubt. We reviewed it from another pathologist. He tells you it is tuberculosis. Ultimately, the slides were sent to Tata Memorial, Bombay. The report from there was quasi tuberculosis, quasi sarcoidosis. What should a clinician do? A thorough review of the patient, a re-examination of the patient, re-analysis of the patient. We found he had a patch on his skin. A biopsy of that skin showed that patient had a cutaneous lymphoma. So, review is very important. A review has to be historical. That means you go back to the patient, you understand his problem again. It has to be clinical. You put your hands again on the patient. It has to be investigative. Review, a CT done, can be reviewed again, can be reviewed by another radiologist again. And it has to be managerial review. That if we are managing him in this way, can a policy B be tried on it? Could a policy C be tried on it? We had a patient in ward 5. He had a cavity in upper lung. First thing which comes in our mind, in our setup, is tuberculosis. We got no yield from his sputum. We thought vasculitis as a cause, Wegener's as a cause, aspergillus as a cause, HIV as a cause. We investigated him for around 20-30 days in our ward. We could not come to a conclusion. We discharged the patient. His 7th sample came sputum for AAV positive. He was treated. My point of telling you is that a review is important. Not that microbiology missed the sputum AAV that time. No. Probably the microorganism can remain in a cavity in such a way it does not shed in the earlier 4-3-4 culturally, cost-effective wise, goal-oriented wise, and result-oriented. Somebody was talking in their lecture that we should be sympathetic to the patient. No, we should not be sympathetic. You should be empathic with the patient. There's a difference being sympathetic and empathic. If you become sympathetic, you will not be a professional, but you have to be empathic. A rational, what sort of rationality we need to have? A patient operated in SMHS hospital for lab coli. After some time develops a effusion, comes to us, and we find that he has a collection in his abdomen. I tell my senior resident it is better it is Saturday evening and we take help from surgeons. Surgeons say that it is better that we do a pigtail drainage. We contact the respective department for a pigtail drainage. They say it is a Saturday evening, we do it Sunday morning. I am after my senior resident who is in the audience right now. Sunday morning they say it is a weekend, we do it next day morning. We do Monday morning. Monday morning they had a huge rush of patients. They do it on the Tuesday morning. Tuesday morning another person sees him, says him that we should better do a CT first and then do a drainage. Are we doing rationality? Are we doing justice? If we had to do CT, it could have been done on Saturday morning. We had time, we had avenues. So we need to review ourselves. Cultural. Another patient with us, whom we thought that she has a Gujar lung. She had a bilateral infiltrates, a reticular pattern in her lungs. So what to do with her? Should we proceed to investigate her, or should we, short of investigations, label her and send her home? Because we know that she belongs to the Gujar area, she lives in Dokas, she has exposure to the biomass. But the 21st century says it is better that we investigate rather than just imply. This patient was subjected for a biopsy and we are awaiting a biopsy. And where we do wrong, I want to tell you that also. Another patient, same reticular pattern, we got a CT done, it was organizing pneumonia. We thought it is a cryptogenic organizing pneumonia. We put her on steroids. But before discharge, we thought that let us do a lung biopsy. Yesterday in my OPD, we saw the report. We were not correct. It was not organizing pneumonia. Patient has a metastatic adenocarcinoma. So, my point of telling you is that there is a need to readdress things, especially in the present context. And this cannot be done by machines. We are presenting this scenario in critical care Kochi around 10 days from now. A young girl comes to us, pregnant with tuberculosis, and we put her on anti-tubercular drugs. But she develops a disease around 3 to 4 weeks after taking AGT. She develops skin lesions. In our wildest thoughts, we had not thought that this is because of the anti-tubercular drug she had. Because we had never conceptualized, we had not gone to the literature that it can take 3 to 4 weeks for these drugs to have manifestations on skin. This made us learn. And every person in our ward now, whenever skin patient comes with a manifestation, we think of Rett syndrome. The aim is to highlight that you need to be in touch with the latest developments at any point of time. So management-wise, the clinician has to be a band master. He is the band master of this orchestra. He has to make the paramedical staff, paramedical specialties, whether pathology, whether radiology, whether microbiology, because they don't know the input of the patient. Input lies with the clinical specialties, and it needs a multi-specialty approach. A patient came to general surgery with a mass in their splenic fracture of colon. They referred to the gastroenterology department for a colonoscopy. They did a biopsy. It showed an anaplastic lymphoma. Patient was referred to medical oncology. Medical oncology people thought that it is probably not an oncological issue. They sent it back to gastroenterology. Another colonoscopy was done. It revealed nothing. A third colonoscopy was done. It revealed that metastatic adenocarcinoma. Ultimately, all of us sat together. The surgery people took a decision, we go for a colectomy. They chopped off the splenic fracture of the colon, and the pathology came out to be tuberculosis. So, pitfalls is that we don't have a coordinating cell and we don't have a coordinating attitude with ourselves. So in 21st century, my appeal to you is document whatever things you do, have a confidence of the patient, have a confidence of attendants, downsize aspirations. Don't tell bluebirds to the patients. Whatever you can do within your limitations, tell them transparently and maintain their confidentiality. Pitfalls is we don't have nurses' notes in our files, we don't have pharmacist notes. 21st century, we need to gear up to these things. To augmenting clinical care, we need interdepartmental policy, that means within the consultants of the department. Then we should have an intra-departmental policy. We should have a trans-hospital referral policy, and we should have a higher center referral policy. These should be in black and white, so that the resident staff knows the path which way they have to travel. And we don't have a concept of medical committees in our hospital. In very few hospitals in India, they have a medical committees. But outside India, you have a medical committee, they deliberate among the cases, which are difficult ones, and what should be our modus operandi for them. And this slide is missing in our hospital. Codes, at least code blue, needs to be addressed in our hospital. We don't have a code blue system, but for that we need a addressal system or a belief system. And last word about hospital reviews. We should have a morbidity meet. We don't have a morbidity meet in India in any way. But outside India you have a morbidity meets, where many departments which are concerned about a patient who is stuck up in your hospital, how to proceed. Discharge is not an answer for that. It needs the concerned department to sit up, discuss the issues, review the literature and make a path for this patient. Mortality meets are not there, mortality reviews are there. We are not in the Supreme Court or in a High Court that we present a case and then 20 people start asking questions. It is a review. A review is by a group of people who will go through the files and they will analyze, can something better be done or not? There has to be departmental reviews. There has to be a word about clearances. Many times we find, refer to general medicine, refer to general surgery, refer to OB guys for clearance. There is no word like clearance. You ask opinion from a person. Patient has a bronchial asthma, he is going for a surgery, you send him to the pulmonologist to optimize his treatment for bronchial asthma, but he will not clear you for the surgery. We don't have end-of-life decisions in 21st century, we don't have DNR policy, and we don't have a brain dead.
Excuse me, sir, I just have to be, you're exceeding the time.
Sure.
Just 5 minutes per
Sure. A word about do no harm. Regarding drugs, procedures, adverse reactions, please don't do harm if you don't help the patient. A word about accreditation. This will be 21st century. Medical Council of India is being replaced by National Medical Committee. And they will have accreditation for doctors, for nurses, for lab personnel, for pharmacy personnel. So my last word to you is, let the patient decide. He is coming to you at consultation. Don't impose on him. Do not sympathize, empathize. Do not treat or opinion where you don't specialize. Do not scrub your notes and do not mud slap your friend. Your competitor is not your doctor. Your competitor is the electronic brain, which is coming by 2050. Or if Trump remains there, he may legitimize clones. So clone will be your competitor. This was the change which brought 20th century. Improvement in quality, affordability and consumption of food. It became more available in 20th century. It curbed the diseases and discovery of antibiotics. But in 21st century, are we doomed for destruction? Because we are piling calories more. We are having antibiotic resistance. There may be a silent resistance in the electronic brain which is coming up. Or clones may rebel. Somebody asked Albert Einstein, how will be the Third World War fought? He told, I don't know how Third World War will be fought, but Fourth will be fought with bows and arrows. So much destruction. Are these words of anticipation or destruction? We don't know. But let us try to apply our knowledge and rest leave to Almighty Allah. He will grant us wisdom to rescue. Will He give your helping hand to a person who is drowning? Thank you.
Do we have any questions from the audience? We have 5 minutes for questions. I think there are any questions? No questions. Thank you guys.
Thank you very much.
Now I would like to call on stage Professor Abdul Wahid, HOD Psychiatry, SKIMS Medical College. He'll be talking about a very important issue. Happy to hear him, and I know all of us at times close, all of us sometimes. Please, sir.
Respected Chairperson, dignified audience, Assalamu alaikum and good afternoon. I have been given to speak on doctor-patient relationship, which already I think most of the speakers are connected to and have highlighted in one way or other. And at the outset, I was told only 15 minutes of deliberation is possible. So two things have been compelling me: how to squeeze the topic for a 15 minutes talk and And I speak as a psychiatrist, and most of the audience is a non-psychiatric population, how it will connect. So I try my best to stick to basics, which senior people will find refreshing and younger people may inculcate in their daily clinical skill. So, doctor-patient relationship has a history behind it. It is a history of human evolution in civilization and political movements. And can be discussed from several perspectives. I will leave it behind if I get time further to deliberate upon those perspectives, but let's stick to what doctor-patient relationship is. It is the core of practice of medicine. It is essential to the healing of many patients. It is the foundation on which the effective treatment plan integrating the advances in medical technology and human care can be implemented. And what does the term relationship connote? The relationship in the context of interaction between a patient and a doctor refers neither to structure of a relationship nor the function of a relationship, but it refers to an abstraction which encompasses activities of two interacting systems or persons. As we all know, doctors deal with sick people, not the disease syndromes, and as such, a sick person or sick persons bring into doctor-patient relationships a host of factors which have a lot of interplay in the relationship. These factors stem from biological, psychological, and social spheres. Any doctor who is negligent of such an interplay may miss critical information which is relevant to diagnosis, treatment, compliance, and prognosis. So the apparent intrinsic quality of this unique doctor-patient relationship allows two people previously unknown to each other to feel at ease with variable degree of intimacy. Now this is either way, when it or when not, it depends on how we nurture the relationship. So let's come to what is a doctor-patient relationship. In its most simple or generic form, doctor-patient relationship is defined as coming together of a health seeker or a patient, an expert or a doctor, to identify, understand, and solve the problems of the patient or the health seeker. So both the parties have their own motivating factors and roles to play. Fundamentally, now this is very important, fundamentally it reflects the positive outcomes of social connectedness in the interpersonal influence in the sphere of health and illness. And why is it important to study the relationship? Because see, patients visit their patients when they are most vulnerable and they need to have trust and confidence in their physician. However, when it comes to patient-physician relationship, the two parties are not always aligned. When physicians build a trusting relationship with patients, it ultimately improves the outcome. On an average, 50% of patients left treated for chronic disease do not take their medicine as prescribed. Many a times that decision to take or skip the dose is significantly influenced by the physician-patient relationship. Now this is kind of a slogan. If you are not really engaged with somebody and do not trust them, and they recommend you that you do something, or would you do it, or would you follow through on it? Probably not. That's what exactly is the role of a doctor in this relationship, to guide the patient towards the betterment. We jeopardize our patient's safety and our patient's outcome if we do not develop a trusting, healing relationship between the patient and the physician. How does it develop? The doctor-patient relationship develops during the assessment and evaluation of the patient. The patient observes the thoroughness and sensitivity with which the physician collects information, performs physical examination, and explains tests. Although these steps will be highlighted and discussed, but basically it all starts as a time once the patient enters the doctor's room. It all starts out we are discussing them step by step, but it is all mixed, intermixed. At each step, the physician's clarification of the treatment goals and interventions either builds up the patient's expectation of health and feelings of safety, or creates increase in distress and disease for the patient. So in many aspects, physician is like a good teacher who establishes the context in which learning and growth may occur and anxiety decrease. So what are the elements that make this relationship fruitful, productive, or otherwise? Again, these are, I enumerate them separately, but they go hand in hand. First is respect to consideration, then rapport and empathy, therapeutic alliance, transference and counter-transference. As should happen in all clinical settings, the patient must be treated with respect, and the physician should be considerate of the circumstances of the patient's condition, as the patient is feeling vulnerable and uncertain of what may happen. The success of this initial interview will depend on the physician's ability to allay his excessive anxiety. In a survey of 700 patients, there was substantial agreement that physicians neither have time nor inclination to listen to their patients. That's exactly what is the slogan about. Often, physicians don't understand what their patients want from them. It's really quite simple. The first thing the patients want from their physician is to be respected and listened carefully to. Next is rapport and empathy. As you involve yourself in the evaluation process, verbal and non-verbal, the process of rapport building has already begun. What is rapport? It's a harmonious responsiveness of the physician to the patient and the patient to the physician. It's a comfortable pattern of working together. It implies that there is presence of trust and understanding between the doctor and the patient. It is based on verbal and non-verbal communication on the part of the physician. Now here, the major role is for the physician for rapport development. You show respect, you show consideration. Next, you make him comfortable, have a few words of how are you, what brings you here. You start verbal communication, but apart from that, there is certain non-verbal communication going on, and the patient, as I discussed initially, patient observes the thoroughness and sensitivity with which you are collecting information from the patient. And a head nod, raising an eyebrow, putting your pen down, sometimes leaning forward towards the patient are the cues that hint at that you are listening to the patient or you understand the patient. Rapport is simultaneously joined with empathy, as Dr. Cole was saying, not you don't sympathize with the patient, it's empathizing. Empathy is the ability to understand with feeling terms what the patient experiences. And it means demonstrating an understanding of the patient's pain and distress while maintaining an objective and observant stance. This is very important again. As you develop empathy with the patient, there's a boundary has to be drawn that you may not lose objectivity and professionalism. So empathy, while maintaining objective stance, is professionally the right stand. Now, you reflect back to the patient. Yes, I acknowledge your difficulty, but it must be in terms of your job, your family life, your social life. This will go a long way in making the patient feel understood and secure. It is important for the physician to validate the patient's feelings without making a personal judgment or offering a quick solution. Again, take a break. Don't make a judgment while the patient has talked to you, revealed about certain problem. Be non-judgmental, because being non-judgmental encourages the patient to share more information. That's going to be useful. Now, the core of doctor-patient relationship is therapeutic alliance, and subsequently two more concepts of transference and counter-transference. The term is borrowed from psychoanalysis of Sigmund Freud, but modified over a period of decades. This, you see, when you are with a patient, already a rapport has built, you have empathized. The patient and you feel at ease with each other, with collecting information and whatever. Two things happen. One, you establish contact with the patient based on reality. Second thing, some unconscious factors are beginning to deviate you. Like, you start praying namaz, you want to concentrate on namaz, but somehow certain words, things come to mind, they try to deviate you from that remembering Allah in the true spirit. This is often a problem with all of us. So, therapeutic alliance means you establish a reality-based contact and goal. You set the goals between you and the patient. Of course, you have a headache or you have this problem. Now we are going to have a course of investigation and later on we decide to treat. So this all will go in a reality setting. These are the appointments will be like that, fee will be like that. We will meet on twice a week, once a week, once. This is what is reality component of the relationship in which you stay out of conflict. Simultaneously, two factors are important, which are out of your consciousness and out of consciousness of the patient. These are transference and counter-transference, right? We'll elaborate on this. First, let me continue. Once you have reached the common goals between you and patient have been reached and decided upon, so you start working on this plan, how to implement the effective treatment plan, that is therapeutic alliance. And many times, you will be going astray, the patient will be going astray, deviating from the path. So both parties have to take responsibility of their role. This component of the relationship needs nurturing on the part of the physician, who needs to be alert to the influence of conscious as well as unconscious tendencies of the patient as well as the doctor. But the physician, you see, the patient comes from a diverse background, from a very rural background, socially and economically and educationally. There's a bottom gap between the doctor and the patient. And your skill, your training should tell you how to bridge this gap, how to communicate across this gap. So the patient should feel at ease. He should not feel he is talking to somebody very professionally affluent, socially, upper class person. So this is this capability, how to generate right from the early university. Bridge the gap. You talk to the patient, and big, expert doctors, they are known for this skill. The physician must bridge the gap between the patient and the physician as always present because of their different backgrounds and perceptions of the world. So here comes another component which can affect your relationship with the patient. It's transference and counter-transference. Transference is a tendency we all have to see someone in the present as being like an important person from our past. Right? This process occurs outside our conscious awareness. So you meet somebody today, you don't know why you like him or why you don't like him or you dislike him or her. So these are the effects of our past life and we try to project them onto the present. Similarly, in doctor-patient relationship, this is a potentially either positive, it can contribute in a positive way or it is a negative influence that can destroy the relationship. So once the patient comes to you in this relationship, he has a set of expectations and beliefs and emotions which have been generated from his past, his interaction with the parents or teachers or friends. And this is colored by the patient's past experience. It can be positive or negative. Positive transference will be simple, that the patient has basic trust in the doctor, or in an exaggerated form, it can be he's more idealizing the doctor. He has a big image of doctor which actually is not true. And further dysfunctional positive transfers will be his eroticized fantasy. He or she will go to sleep with the ideas of the doctor, with the dreams and dreams about the doctor. So these are the range of positive transference. And doctor has to be alert about their occurrence. If the patient behaves in a way that it sounds, he takes you as a data as a next to God, you have to be alert to these influences that patient is getting a positive transference but in an exaggerated form which is not professionally right. Similarly, transference experienced by the physician is called counter-transference. He or she can also bring from his or her past influences into the present relationship. doctor can look at the patient from a different perspective. He doesn't know. He begins to like the patient, he begins to dislike the patient. Generally speaking, most of doctors, for them, a patient is a good patient whose symptoms conform to a particular pattern of diagnosis, who is compliant with the treatment, who is not arguing, who is not hostile. But there are patients who do not fall into this category. And for a doctor, he may begin to dislike the patient for these reasons. But there is time. This is the time doctor should step back and try to analyze why I am feeling like this, why I am beginning to dislike the patient. Because it will educate him, it will help him to understand the patient's dynamics as well as encourage his own growth. He will develop further by analyzing these things. So counter-transference reactions experienced by the patient can either be positive or negative, like the one faced by the patient. Now, this doctor-patient relationship, as I said, patterns the history of man. In ancient Egypt, it's doctor-patient relationship started with the active role of the priest for every problem, whether health-related or whether due to disaster or otherwise. People will go to turn to priest, and priest will be all dominating figure in their life, and he will take full command of the problems and the solution. Later came the Greek era, in which democracy took shape, and we saw Hippocrates from the state and Hippocrates both came into being, because that signifies how patient was to be treated. If you have knowledge of the doctor-patient model of doctor-patient relationship, we have active-passive model, we have the guidance participation model, and we have mutual participation model. Earlier, when priest was in command, it was an active-passive model. The patient had to do nothing, everything would be done by the priest, and then it shifted in the democratic setup in Greek to a more respectful position for the patient, and it was a guidance participation model. And in this era, we saw Hippocrates coming into the picture. Then came medieval Europe and Roman Empire fell. Church established its dominance again. All the elite class was associated with church, and priest was again given the authority. And in this context, doctor again began to see himself as someone special in the society. And again, we had an active-passive model in history. Later, in 18th century, with the advancement of microbiology, science, and surgery, patients' illness began to be seen as a symptom of an illness, and he was treated as on the lines of mutual participation, in which the patient was made to understand what is the dynamics of your problem. So this vicissitude of the relationship continued. And today, when in the 19th century, it was Sigmund Freud who discovered that most of the patients who came to his treatment had this basically relationship issues arising from their development. So he gave the concept of psychoanalysis, and the patient, his model was incorporated in the evaluation of the patient, being made equally responsible, because you guide the patient, you analyze his condition, guide him to what is ailing you, and that would make mutual participation. Now,
you have to be quick with this slide.
Okay. Most of the models, doctor-patient models, that have been operating in the past are paternalistic, right? And you can see, if you have informative models, most of these models do not operate even in societies like India or China, because here the paternalistic model continues to dominate. Okay. Here the doctor tends to use a disease-centered model and is focused on reaching a diagnosis rather than patient unique experience. So you diagnose an illness, you don't really have a holistic approach towards the patient in this model. This exemplify, the patient has no say where to stop. Doctor goes on prescribing all the investigations, and it is his say on it. Next is an informative model. Doctor provides relevant information interpretive model, the doctor helps the patient to articulate his or her values through interpretation. Patients have unconscious desires. Their conscious wisdom may not reflect their deepest values, but the doctor is helping him to interpret what he has said. Here, the deliberative model, doctor helps the patient to deliberate well through dialogue and discussion and develop values which are objective and truly worth. The patient's good life consists not in satisfaction of desires but maturity and rationality. So here, the doctor helps him to grow psychologically. So this deliberative model is nothing about me without me. So the patient is made equally responsible for all this, and he has a say, he has an upper hand. Now, what models you operate in your practice, you are the best people to understand. But you have to be aware of which model, like, if you are treating a comatose patient, unconscious patient, so active or passive model will be operative. And once the patient regains consciousness, you have to do guidance participation, because you have to guide him towards rehabilitation, but it's a problem. And if you are in kind of a behavioral problem, mutual participation will be the model practice. So what are the contemporary issues involved now? As you said, 21st century has brought a lot of challenge to medical practice. But it is not as bad as it is in the West. But you must, all the young doctors need to be told about the sweetness of the doctor-patient relationship, because electronic gadgets, electronic aids are frequently being used now in this, and you cannot, it cannot be inevitable. They have to be there. They will be there in more and more numbers. But the doctor-patient relationship has to survive, and how to survive, how to make it productive and sweet is by giving proper training to our young doctors. What are the issues? Issues involved are that litigation issues, as Dr. Cole has highlighted. But it's our model which operates in India has less litigation rates. And what is the use of internet by the patient? It also puts doctor in a dilemma, because already the patient has a lot of information, knowledge about his illness, and whether it's right or wrong is arguable. But of course, it's not all that wrong also. There are issues which are not very information on internet is not true. So finally, the guru physician treats the disease, the great physician treats the patient who has the disease. So holistic approach is the message which should be adopted from the 21st century. As Dr. Cole said, machine cannot really replace the man. Thank you.
Questions in the audience?
Culturally, cost-effective wise, goal-oriented wise, and result-oriented. Somebody was talking in their lecture that we should be sympathetic to the patient. No, we should not be sympathetic. You should be empathic with the patient. There's a difference being sympathetic and empathic. If you become sympathetic, you will not be a professional, but you have to be empathic. Rational, what sort of rationality we need to have? A patient operated in SMHS hospital for lab coli. After some time develops a effusion, comes to us, and we find that he has a collection in his abdomen. I tell my senior resident it is better it is Saturday evening, and we take help from surgeons. Surgeons say that it is better that we do a pigtail drainage. We contact the respective department for a pigtail drainage. They say it is a Saturday evening, we do it Sunday morning. I am after my senior resident who is in the audience right now. Sunday morning they say it is a weekend, we do it next day morning. We do Monday morning. Monday morning there is a huge rush of patients, they do it on the Tuesday morning. Tuesday morning another person sees him, says him that we should better do a CT first and then do a drainage. Are we doing rationality? Are we doing justice? If we had to do CT, it could have been done on Saturday morning. We had time, we had avenues. So we need to recover. Cultural. Another patient with us, whom we thought that she has a Gujarla. She had a bilateral infiltrates, a reticular pattern in her lungs. So what to do with her? Should we proceed to investigate her, or should we, short of investigations, label her and send her home? Because we know that she belongs to a Gujar area, she lives in Dokas, she has exposure to the biomass. But the 21st century says, it is better that we investigate rather than just imply. This patient was subjected for a biopsy and we are awaiting a biopsy. And where we do wrong, I want to tell you that also. Another patient, same reticular pattern, we got a CT done, it shows organizing pneumonia. We thought it is a cryptogenic organizing pneumonia. We put her on steroids. But before discharge, we thought that let us do a lung biopsy. Yesterday in my OPD, we saw the report. We were not correct. It was not organizing pneumonia. Patient has a metastatic adenocarcinoma. So, my point of telling you is that there is a need to readdress things, especially in the present context. And this cannot be done by machines. We are presenting this scenario in critical care Kochi around 10 days from now. A young girl comes to us, pregnant with tuberculosis, and we put her on anti-tubercular drugs. But she develops a disease around 3 to 4 weeks after taking ATT. She develops skin lesions. In our wildest thoughts, we had not thought that this is because of the anti-tubercular drug she had. Because we had never conceptualized, we had not gone to the literature that it can take 3 to 4 weeks for these drugs to have manifestations on skin. This made us learn. And every person in our ward now, whenever skin patient comes with the manifestation, we think of Rett syndrome. The aim is to highlight that you need to be in touch with the latest developments at any point of time. So management-wise, the clinician has to be a band master. He is the band master of this orchestra. He has to make the paramedical staff, paramedical specialties, whether pathology, whether radiology, whether microbiology, because they don't know the input of the patient. Input lies with the clinical specialties, and it needs a multi-specialty approach. A patient came to general surgery with a mass in their splenic fracture of colon. They referred to the gastroenterology department for a colonoscopy. They did a biopsy. It showed an anaplastic lymphoma. Patient was referred to medical oncology. Medical oncology people thought that it is probably not an oncological issue. They sent it back to gastroenterology. Another colonoscopy was done. It revealed nothing. A third colonoscopy was done. It revealed that metastatic adenocarcinoma. Ultimately, all of us sat together. The surgery people took a decision, we go for a colectomy. They chopped off the splenic fracture of the colon, and the pathology came out to be tuberculosis. So, pitfalls is that we don't have a coordinating cell and we don't have a coordinating attitude with ourselves. So in 21st century, my appeal to you is document whatever things you do, have a confidence of the patient, have a confidence of attendants, downsize aspirations. Don't tell bluebirds to the patients. Whatever you can do within your limitations, tell them transparently and maintain their confidentiality. Pitfalls is we don't have nurses' notes in our files, we don't have pharmacist notes. 21st century, we need to get up to these things. To augmenting clinical care, we need interdepartmental policy, that means within the consultants of the department. Then we should have an intra-departmental policy. We should have a trans-hospital referral policy, and we should have a higher center referral policy. These should be in black and white, so that the resident staff knows the path which way they have to travel. And we don't have a concept of medical committees in our hospital. In very few hospitals in India, they have a medical committees. But outside India, you have a medical committee, they deliberate among the cases, which are difficult ones, and what should be our modus operandi for them. And this slide is missing in our hospital. Codes, at least code blue, needs to be addressed in our hospital. We don't have a code blue system, but for that we need a addressal system or a bleep system. And last word about hospital reviews. We should have a morbidity meet. We don't have a morbidity meet in India in any way. But outside India, you have a morbidity meets, where many departments which are concerned about a patient who is stuck up in your hospital, how to proceed. Discharge is not an answer for that. It needs the concerned department to sit up, discuss the issues, review the literature, and make a path for this patient. Mortality meets are not there, mortality reviews are there. We are not in the Supreme Court or in a High Court that we present a case and then 20 people start asking questions. It is a review. A review is by a group of people who will go through the files and they will analyze, can something better be done or not? There has to be departmental reviews. There has to be a word about clearances. Many times we find, refer to general medicine, refer to general surgery, refer to OB guys for clearance. There is no word like clearance. You ask opinion from a person. Patient has a bronchial asthma, he is going for a surgery, you send him to the pulmonologist to optimize his treatment for bronchial asthma, but he will not clear you for the surgery. We don't have end-of-life decisions in 21st century, we don't have DNR policy, and we don't have a brain dead.
Excuse me, sir, I just have to be, you're exceeding the time.
Sure.
Just 5 minutes per
Sure. A word about do no harm. Regarding drugs, procedures, adverse reactions, please don't do harm if you don't help the patients. A word about accreditation. This will be 21st century. Medical Council of India is being replaced by National Medical Committee. And they will have accreditation for doctors, for nurses, for lab personnel, for pharmacy personnel. So my last word to you is, let the patient decide. He is coming to you at consultation. Don't impose on him. Do not sympathize, empathize. Do not treat or opinion where you don't specialize. Do not scrub your notes and do not mud slap your friend. Your competitor is not your doctor. Your competitor is the electronic brain, which is coming by 2050. Or if Trump remains there, he may legitimize clones. So clone will be your competitor. This was the change which brought 20th century. Improvement in quality, affordability and consumption of food. It became more available in 20th century. It curbed the diseases and discovery of antibiotics. But in 21st century, are we doomed for destruction? Because we are piling calories more. We are having antibiotic resistance. There may be a synaptic resistance in the electronic brain which is coming up. Or clones may rebel. Somebody asked Albert Einstein, how will be the Third World War fought? He told, I don't know how Third World War will be fought, but Fourth will be fought with bows and arrows. So much destruction. Are these words of anticipation or destruction? We don't know. But let us try to apply our knowledge and rest leave to Almighty Allah. He will grant us wisdom to rescue. Will He give your helping hand to a person who is drowning? Thank you.
Do we have any questions from the audience? We have 5 minutes for questions. I think there are any questions? No questions. Thank you, guys.
Thank you very much.
Now, I would like to call on stage Professor Abdul Wahid, HOD Psychiatry, SKIMS Medical College. He'll be talking about a very important, deeply happy to hear him, and I know all of us at that close, all of us are happy. Please, sir.
Respected chairperson, dignified audience, Assalamu alaikum and good afternoon. I have been given to speak on doctor-patient relationship, which already I think most of the speakers are connected to and have highlighting in one way or other. And at the outset, I was told only 15 minutes of deliberation is possible. So two things have been compelling me, how to squeeze the topic for a 15-minute talk, and I speak as a psychiatrist and most of the audience is a non-psychiatric population, how it will connect. So I'll try my best to stick to basics, which senior people will find refreshing and younger people may inculcate in their daily clinical skill. So, doctor-patient relationship has a history behind it. It is a history of human evolution in civilization and political movements. And can be discussed from several perspectives. I will leave it behind if I get time further to deliberate upon those perspectives, but let's stick to what doctor-patient relationship is. It is the core of practice of medicine. It is essential to the healing of many patients. It is the foundation on which the effective treatment plan integrating the advances in medical technology and human care can be implemented. And what does the term relationship connote? The relationship in the context of interaction between a patient and a doctor refers neither to structure of a relationship nor the function of a relationship, but it refers to an abstraction which encompasses activities of two interacting systems or persons. As we all know, doctors deal with sick people, not the disease syndromes, and as such, a sick person or sick persons bring into doctor-patient relationships a host of factors which have a lot of interplay in the relationship. These factors stem from biological, psychological, and social spheres. Any doctor who is negligent of such an interplay may miss critical information which is relevant to diagnosis, treatment, compliance, and prognosis. So the apparent intrinsic quality of this unique doctor-patient relationship allows two people previously unknown to each other to feel at ease with variable degree of intimacy. Now this is either way, whether it or whether not, it depends on how we nurture the relationship. So let's come to what is a doctor-patient relationship. In its most simple or generic form, doctor-patient relationship is defined as coming together of a health seeker or a patient, an expert or a doctor, to identify, understand, and solve the problems of the patient or the health seeker. So both the parties have their own motivating factors and roles to play. Fundamentally, now this is very important, fundamentally it reflects the positive outcomes of social connectedness in the interpersonal influence in the sphere of health and illness. And why is it important to study the relationship? Because see, patients visit their physicians when they are most vulnerable and they need to have trust and confidence in their physician. However, when it comes to patient-physician relationship, the two parties are not always aligned. When physicians build a trusting relationship with patients, it ultimately improves the outcome. On an average, 50% of patients that are treated for chronic disease do not take their medicine as prescribed. Many a times that decision to take or skip the dose is significantly influenced by the physician-patient relationship. Now this is kind of a slogan. If you are not really engaged with somebody and do not trust them, and they recommend you that you do something, or would you do it, or would you follow through on it? Probably not. That's what exactly is the role of a doctor in this relationship, to guide the patient towards the betterment. We jeopardize our patient's safety and our patient's outcome if we do not develop a trusting, healing relationship between the patient and the physician. How does it develop? The doctor-patient relationship develops during the assessment and evaluation of the patient. The patient observes the thoroughness and sensitivity with which the physician collects information, performs physical examination, and explains tests. Although there is steps, these steps will be highlighted and discussed, but basically it all starts as a time once the patient enters the doctor's room. It all starts, we are discussing them step by step, but it is all mixed, intermixed. At each step, the physician's clarification of the treatment goals and interventions either builds up the patient's expectation of health and feelings of safety, or creates increase in distress and disease for the patient. So in many aspects, physician is like a good teacher who establishes the context in which learning and growth may occur and anxiety decrease. So what are the elements that make this relationship fruitful, productive, or otherwise. Again, these are, I enumerate them separately, but they go hand in hand. First is respect to consideration, then rapport and empathy, therapeutic alliance, transference and counter-transference. As should happen in all clinical settings, the patient must be treated with respect, and the physician should be considerate of the circumstances of the patient's condition, as the patient is feeling vulnerable and uncertain of what may happen. The success of this initial interview will depend on the physician's ability to allay his excessive anxiety. In a survey of 700 patients, there was substantial agreement that physicians neither have time nor inclination to listen to their patients. That's exactly what is the slogan about. Often, physicians don't understand what their patients want from them. It's really quite simple. The first thing the patients want from their physician is to be respected and listened carefully to. Next is rapport and empathy. As you involve yourself in the evaluation process, verbal and non-verbal, the process of rapport building has already begun. What is rapport? It's a harmonious responsiveness of the physician to the patient and the patient to the physician. It's a comfortable pattern of working together. It implies that there is presence of trust and understanding between the doctor and the patient. It is based on verbal and non-verbal communication on the part of the physician. Now here, the major role is for the physician for rapport development. You show respect, you show consideration. Next, you make him comfortable, have a few words of how are you, what brings you here. You start verbal communication, but apart from that, there is certain non-verbal communication going on, and the patient, as I discussed initially, patient observes the thoroughness and sensitivity with which you are collecting information from the patient. And a head nod, raising an eyebrow, putting your pen down, sometimes leaning forward towards the patient, are the cues that hint at that you are listening to the patient or you understand the patient. Rapport is simultaneously joined with empathy, as Dr. Cole was saying, not you don't sympathize with the patient, it's empathizing. Empathy is the ability to understand with feeling terms what the patient is experiencing. And it means demonstrating an understanding of the patient's pain and distress while maintaining an objective and observant stance. This is very important again. As you develop empathy with the patient, there's a boundary has to be drawn that you may not lose objectivity and professionalism. So empathy, while maintaining objective stance, is professionally the right stand. Now, you reflect back to the patient. Yes, I acknowledge your difficulty, but it must be in terms of your job, your family life, your social life. This will go a long way in making the patient feel understood and secure. It is important for the physician to validate the patient's feelings without making a personal judgment or offering a quick solution. Again, take a break. Don't make a judgment while the patient has talked to you, revealed about certain problem. Be non-judgmental, because being non-judgmental encourages the patient to share more information that's going to be useful. Now, the core of doctor-patient relationship is therapeutic alliance, and subsequently two more concepts of transference and counter-transference. The term is borrowed from psychoanalysis of Sigmund Freud, but modified over a period of decades. This, you see, when you are with a patient, already a rapport has built, you have empathized. The patient and you feel at ease with each other, with collecting information and whatever. Two things happen. One, you establish contact with the patient based on reality. Second thing, some unconscious factors are beginning to deviate. Like, you start praying namaz. You want to concentrate on namaz, but somehow certain words, things come to mind, they try to deviate you from that remembering a lot in the true sequence. This is often a problem with all of us. So therapeutic alliance means you establish a reality-based contact and goal. You set the goals between you and the patient. Of course, you have a headache or you have this problem. Now we are going to have a course of investigation and date on which decide treatment. So this all will go in a reality setting. These are the appointments will be like that, fee will be like that. We will meet on twice a week, once a week, once. This is what is the reality component of the relationship in which you stay out of conflicts. Simultaneously, two factors are important, which are out of your consciousness and out of consciousness of the patient. These are transference and counter-transference, right? We'll elaborate on this first. Let me continue. Once you have reached common goals between you and patient have been reached and decided upon, so you start working on this plan, how to implement the effective treatment plan that is therapeutic alliance. And many times, you will be going astray, the patient will be going astray, deviating from the path. So both parties have to take responsibility of their role. This component of the relationship needs nurturing on the part of the physician, who needs to be alert to the influence of conscious as well as unconscious tendencies of the patient as well as the doctor. But the physician, you see, the patient comes from a diverse background, from a very rural background, socially and economically and educationally. There's a lot of gap between the doctor and the patient. And your skill, your training should tell you how to bridge this gap, how to communicate across this gap. So the patient should feel at ease. He should not feel he is talking to somebody very professionally affluent, socially, upper class person. So this is this capability, how to generate right from the early university. Bridge the gap. You talk to the patient, and big, expert doctors, they are known for this skill. The physician must bridge the gap between the patient and the physician as always present because of their different backgrounds and perceptions of the world. So here comes another component which can affect your relationship with the patient. It's transference and counter-transference. Transference is a tendency we all have to see someone in the present as being like an important person from our past. Right? This process occurs outside our conscious awareness. So you meet somebody today, you don't know why you like him or why you don't like him or you dislike him or her. So these are the effects of our past life and we try to project them onto the present. Similarly, in doctor-patient relationship, this is a potentially either positive, it can contribute in a positive way or it is a negative influence that can destroy the relationship. So once the patient comes to you in this relationship, he has a set of expectations and beliefs and emotions which have been generated from his past, his interaction with the parents or teachers or friends. And this is colored by the patient's past experience. It can be positive or negative. Positive transference will be simple, that the patient has basic trust in the doctor, or in an exaggerated form, it can be he's more idealizing the doctor. He has a big image of doctor which actually is not true. Further dysfunctional positive transfers will be his eroticized fantasy. He or she will go to sleep with the ideas of the doctor, with the dreams and dreams about the doctor. So these are the range of positive transference. And doctor has to be alert about their occurrence. If the patient behaves in a way that it sounds, he takes you as a data as a next to God, you have to be alert to these influences that patient is getting a positive transference but in an exaggerated form which is not professionally right. Similarly, transference experienced by the physician is called counter-transference. He or she can also bring from his or her past influences into the present relationship. Doctor can look at the patient from a different perspective. He doesn't know. He begins to like the patient. He begins to dislike the patient. Generally speaking, most of doctors, for them, a patient is a good patient whose symptoms conform to a particular pattern of diagnosis. who is compliant with the treatment, who is not arguing, who is not hostile. But there are patients who do not fall into this category. And for a doctor, he may begin to dislike the patient for these reasons. But there is time. This is the time doctor should step back and try to analyze why I am feeling like this, why I am beginning to dislike the patient. Because it will educate him, it will help him to understand the patient's dynamics as well as encourage his own growth. He will develop further by analyzing these things. So counter-transference reactions experienced by the patient can either be positive or negative, like the one faced by the patient. Now, this doctor-patient relationship, as I said, patterns the history of man. In ancient Egypt, it's doctor-patient relationship started with the active role of the priest for every problem, whether health-related or whether due to disaster or otherwise. People will go to turn to priest, and priest will be all dominating figure in their life, and he will take full command of the problems and the solution. Then later came the Greek era, in which democracy took shape, and we saw Hippocrates from the state and Hippocrates both came into view, because that signifies how patient was to be treated. If you have knowledge of the doctor-patient model of doctor-patient relationship, we have active-passive model, we have the guidance participation model, and we have mutual participation model. Earlier, when priest was in command, it was an active-passive model. The patient had to do nothing, everything would be done by the priest, and then it shifted in the democratic setup in Greek to a more respectful position for the patient, and it was a guidance participation model. And in this era, we saw Hippocrates coming into the picture. Then came medieval Europe and Roman Empire fell. Church established its dominance again. All the elite class was associated with church, and priest was again given the authority. And in this context, doctor again began to see himself as someone special in the society. And again, we had an active-passive model in history. Later, in 18th century, with the advancement of microbiology, science, and surgery, patients' illness began to be seen as a symptom of an illness, and he was treated as on the lines of mutual participation, in which the patient was made to understand what is the dynamics of your problem. So this vicissitude of the relationship continued. And today, when in the 19th century, it was Sigmund Freud who discovered that most of the patients who came to his treatment had this basically relationship issues arising from their development. So he gave the concept of psychoanalysis, and the patient, this model was incorporated in the evaluation of the patient, being made equally responsible, because you guide the patient, you analyze his condition, guide him to what is ailing you, and that would make mutual participation. Now,
you have to be quick with this slide.
Okay. Most of the models, doctor-patient models, that have been operating in the past are paternalistic, right? And you can see, if you have informative models, most of these models do not operate even in societies like India or China, because here the paternalistic model continues to dominate. Okay. Here the doctor tends to use a disease-centered model and is focused on reaching a diagnosis rather than patient unique experience. So you diagnose an illness, you really have a holistic approach towards the patient in this model. This exemplify, the patient has no say where to stop. Doctor goes on prescribing all the investigations, and it is his say on it. Next is an informative model. Doctor provides relevant information, and the patient makes a decision. Next, in interpretive model, the doctor helps the patient to articulate his or her values through interpretation. Patients have unconscious desire. Their conscious decision may not reflect their deepest values, but the doctor is helping him deliberative model, doctor helps the patient to deliberate well through dialogue and discussion and develop values which are objective and truly worth. The patient's good life consists not in satisfaction of desires but maturity and rationality. So here doctor helps him to grow psychologically. So this is deliberative model is nothing about me without me. So the patient is made equally responsible for all this. And he has a say, he has an upper hand. Now, what models you operate in your practice, you are the best people to understand. But you have to be aware of which model, like, if you are treating a comatose patient, unconscious patient, so active or passive model will be operative. And once the patient regains consciousness, you have to guide this participation because you have to guide him towards rehabilitation, but it's a problem. And if you are in kind of a behavioral problem, mutual participation will be the model practice. So what are the contemporary issues involved now? As you said, 21st century has brought a lot of challenge to medical practice. But it is not as bad as it is in the West. But you must, all the young doctors need to be told about the sweetness of the doctor-patient relationship because electronic gadgets, electronic aids are frequently being used nowadays, and you cannot, it cannot be inevitable. They have to be there. They will be there in more and more numbers. But the doctor-patient relationship has to survive, and how to survive, how to make it productive and sweet is by giving proper training to our young doctors. What are the issues? Issues involved are that litigation issues, as Dr. Paul has highlighted. But it's our model which operates in India has less litigation rates. And what is use of internet by the patient? It also puts doctor in a dilemma because already the patient has a lot of information, knowledge about his illness, and whether it's right or wrong is arguable. But of course, it's not all that wrong also. There are issues which are not very good. Every information on the internet is not true. So finally, the guru physician treats the disease, the great physician treats the patient who has the disease. So holistic approach is the message which should be adopted from the 21st century. As Dr. Cole said, machine cannot really replace the man. Thank you.
Do we have any questions in the audience?
I would now request Professor Nisar Ahmed Rambu to present the memento to Dr. Ejaz Ravi Kaur. Moving on to our next session, we all must be familiar with the fact that any life-threatening disease can cause immunocompromised state, and those COVID infections can add to the distress of the patient. Hence, a well-scrutinized, educated staff, a multidisciplinary team approach, a well-developed action plans, and up-to-date policies and news is required for effective hospital infection control. To enhance our knowledge, I would like to invite our next panel of chairpersons to come on stage and start our next session. That is, Hospital Infection Control, Biomedical Waste Management and Communication Skills. Please welcome Professor Zahoor Ahmed Wafai, Head of the Department of Clinical Pharmacology. I now request you to welcome Professor Fazal Parvez from the Department of Surgery.
Personality is something is true.
Dr. T.K. Koku, who conducts his.
I'll try to live up to that. My talk has come at a time which sequence after a doctor-patient relationship. Now, I'll try to speak about doctor-hospital relationship. But forgive me about saying doctor. By doctor, I mean whosoever is associated with the hospital. It is a paramedic, it's a lab technician, it's a nurse, and it's a doctor in itself. So, let us start. Most of us do believe that hospitals are temples of healing, and we have a very noble profession which we belong to, and doctor is supposed to be a savior of mankind. But do we believe it, or do we practice it, is the thing which we have to ponder on. The first requirement of a doctor, I mean all of us in the hospital, is that we should do sick no harm. Sick patient is with anything, but we should not put any more troubles in his or her kitty. And the first and the most important trouble we can give him or her in this hospital is giving the infection. These infections can be caused either by a pathogenic organism, which is a bacteria, a fungus, or a protozoa, or anything like a non-pathogenic organism. As our theme of the day is 21st century and our responsibilities. In 21st century, we are more concerned with non-pathogenic becoming pathogenic, which we have come across and which will be having much and more frequently. Even toxins add to our misery for the patients we are dealing with. How do these microorganisms spread in the hospital? They spread by the airborne infection, by the oral route, or insects and pests. And I am sure most of us know we have a galore of pests and insects in our setting also. We need to do something about that. And the medium is the body fluids, which comprises of the blood, tears, anything, even saliva, sputum, wound drainages or pus. And it can be by touching. And the touching is by transmitting the infection through your hands or through the secretions, or even the droplets. And in droplets, especially in this part of the year, and we are facing the severe winter, coughing, sneezing, and cold is one of the commonest ways. Even laughing and talking can cause transmission of it. That doesn't mean we should not laugh or talk. Do it with some precautions. Who are at the risk? These are anybody who has a decreased resistance to avoid disease or catching of disease. And these people are who have already an existing illness or who are fatigued, because fatigue reduces their ability to curb up, and the stress for the elderly, because all of them have a weaker immune system or a lower resistance, and especially their repeated encounters in the hospital put them to a greater risk, and also a longer chance of remaining sick for a longer period. How to control it? Simplest thing, use your common sense, and the common sense is the cure for everything. Wash your hands, which we take most casually, and wear gloves when needed. Do not touch bad objects, I mean contaminated objects. Touch clean objects only. And if you have to touch contaminated objects, use some precautions. All those guidelines which we may be discussing now are meant for all the workers who are working in the hospital, may it be the sweeper or the top boss. And we have framed some universal precautions for any one of us to follow. We should treat any body fluid, any broken skin, pus, or any dressing like infected or contaminated. And the universal cautions are: wear gloves when you anticipate contact with blood, body fluids, secretions, excretions, broken skin or human tissue. Wearing of gloves is a must that time. And whatever contaminated disposals you have, bag them. Bag them for disposal at an appropriate time and place. And again, important thing is clean all the surfaces which may be contaminated or which you may have contaminated. And clean all the infectious waste or contamination from even the beds and the wheelchairs or trolleys, which you think are innocuous. They are not. What can we do to prevent all these infections or the spread of these infections? Good hand washing. That is the crux of the issue. This is the most effective method, and it has been seen effective in almost 50% of prevention of infections. And for good hand washing, you need, in 21st century, emphasis is on alcohol-based hand cleaners. Though washing with soap and water also helps, but do avoid touching your contaminated or those areas which infest or which harbor some organisms, like your tip of the nose or the mouth and even the eyes. When you cough into your collar, which may sound crude because it's not so easy to pull your collar and cough into it, but you can cough into your armpit. This will avoid your hands getting contaminated and you subsequently infecting other people. Use tissues. If you can't cough in your collar or armpit, use tissues and put these tissues in the waste basket. As I said, almost 35 to 50% of these hospital-associated infections are caused by these 5 factors, which I have enumerated. Urinary catheters form the chunk of it, then vascular access lines, support of the pulmonary functions, that is the ventilator-assisted ventilations, surgical procedures, and precautions like hand hygiene. So I will emphasize on hand washing more. When you do hand washing, remove your jewelry. In any way, a hospital is a place where you don't come with fancy things. So jewelry and watches are to be removed. Rub vigorously your hands, 2 of your hands together for almost 20 seconds. And you cannot always count the watch. The best thing is say, happy birthday, happy birthday. You sing it twice from within yourself, not so loud that those who don't have a birthday, you sing it to them. And it consumes 20 seconds. Good enough for your hands to clean. Rinse your fingers. And your fingers at the time of rinsing should be facing downwards, so whatever droplets or whatever drops are there of water will get down drained. Dry your hands. Dry it with tissue, plain tissue, a paper towel or a cloth towel. And after drying, don't turn off the faucets with your hands. That's again common sense which is there. Remove your dirt, because in 21st century you may have little access to water, but dirt is to be removed. And then apply a dime-sized alcohol-based sanitizer on your hand. Rub it vigorously. Rub it on all the surfaces in your webs and rub until it is absorbed. If you don't have dirt removed from your hands, none of these alcohol-based or any sanitizers is going to be there. Then, main issue, every time there is a demand for gloves from every corner. When should we use gloves? Anyone does. When you have a possible contact with blood, any body fluid, or open wounds on your personal rings, you need to use gloves. When you are performing mouth care, when you are performing a perineal care, or when you are dealing with a broken skin. You should use your gloves when you have some open cuts on your own hands, or you are shaving a consumer, which we frequently need to do, especially in surgical practices. When you are handling the soiled linen, because at times you have to handle the linen, whether it be a doctor or a caretaker who has to. Then use gloves. When you should change the gloves, again equally important, change when you have touched a contaminated surface or an infected patient, when you have touched the mucous membrane or a broken skin, or these gloves have become wet, soiled or torn. Even they have been used for a longer time, you need to change them. Let me tell you, we had a study on the gloves permeability long back in our department, and we have found that even second use of a glove makes it permeable to microorganisms. So I will suggest, but not force you to, because then you will be asking for more and more gloves. Hand washing, as I said, is a time-proven fact, and it has been seen that alcohol-based rubs are recognized, as I explained also, and now we have to act and use them. And these are alcohol-based rubs. WHO had come with a program which started in May 2009, and it is going on, and it will be culminated in 2020. It's a Safe Patient Initiative. I suggest you be part of it, register yourself, and see what they recommend and follow them. Because clean care is safe care. There are, as I said, 5 reasons for more than 50% of these hospital-associated infections. And amongst them, hand hygiene is responsible for stopping or giving more than 50% of these infections. I already discussed that, and then the prime of it was urinary catheter-associated hospital-associated infections. In this, I would suggest, you are the best people to judge whether to use a catheter or not. If you can avoid it. And if you have used it, limited duration. Because for a longer period, catheter remains, chances of acquiring a urinary tract infections are more. And while handling a catheter or inserting a catheter, use hand hygiene as meticulously as we discussed just now. And this hand hygiene is to be implemented before insertion and at the time of removal of the catheter or for any manipulation. Then aseptic techniques, you all know, are necessary, and you will just try the equipment, I mean a catheter which has to be sterile. You may clean the meatal area for insertion, but there is no need of antisepsis, as has been studied. But the choice and experience of anybody doing this procedure is paramount. Secure this indwelling catheter, then you need not to do more manipulations. Maintain a closed drainage system, there will be chances of which frequently we encounter or we are forced to perform because there is a blockage. Avoid it. Systemic antimicrobials are used as prophylaxis, but no logic, as so many studies have said. Don't change catheters as frequently as you may think of. Follow a pattern. There is a talk about silver-coated and antibacterial-coated catheters, but do not use them routinely. For the reasons these may create some antimicrobial resistance also. And asymptomatic bacteriuria are usually treated or sought out. Please don't do that. Do not treat any of these asymptomatic UTIs, asymptomatic bacteriuria, because these cannot be necessarily UTIs. And don't do invasive procedures except when a urological demand is there. Second most important thing after catheter-associated infections is vascular access lines induced infections. Here is the diagrammatic representation. What are the 3 important ports through which the infections enter the body? It's intraluminal from the tubes and hubs, it's extraluminal from the skin, and it's hematogenous from the distal sites. And it can be taken care of by trial barrier precautions by skin antisepsis, again by alcohol-based chlorhexidine containing routes. Always try to go through the subclavian route, which is very rarely followed. Daily review of lines is very important, and catheter care is important. It is to be done regularly. Always respect the dressing change methodology in your hospital. There must be some procedures for that. SOP is followed. Then comes to support of a pulmonary function, that is ventilator-associated pneumonia. The devices responsible for these ventilator-assisted respirations are enumerated. Invasive ventilation is done. Invasive ventilation duration is important. Re-intubation which is one of the causes of these intubation. Medication is important. It may catch hold of one organism but not other one, so you have to do appropriate medication. Prior antibiotic treatment, you have to judge it, whether you would like to give it or not, and sedation. These are the things which a physician or a critical care physician will take into consideration. And the patients usually at risk are those who have higher age group, those who have gone through the burns or are comatose or have a lung disease or immunosuppression or malnutrition or any kind. For all these things, you need to educate the staff who are handling this critical care setting. Keep the patient in good hygiene, and isolation is paramount importance. Surveillance of infection, I mean, if the patient shows any sign of infection, to act promptly. Otherwise, you may land in trouble. And use the appropriate antibiotic for adequate length. And most important is that you need to have good number of staff there, because critical care area needs one-to-one attention. Avoid intubation and re-intubation, as I said earlier also. Prefer non-invasive ventilations, and continuous subglottic drainage is to be done. Aspiration is to be done, because the stagnation may cause more and more infections. It has been debated whether oral chlorhexidine application will reduce these ventilator-associated pneumonias or not, but I have come across only one study, so choice is yours. I don't recommend, but I can't force. Whether to use systemic and enteral antibiotics or not, again the choice of the critical care physician. Some people use selective decontamination of the digestive tract. You are the better judges, but not much literature is available for that. So it's not recommended for routine use. Systemic antibiotics in ventilator-associated pneumonia, selected patient groups need them, because you can't give prophylactic antibiotics for all. And again, I say only one study for 24-hour antibiotic prophylaxis. So if you can avoid it, avoid it. Then surgical procedure-associated infections. I wonder if one of the chairpersons who happens to be a surgeon will agree to whatever I say, but these are the things from the records. To prevent, we have some objectives. Surgical site preparation, very important, paramount. You have to take care of that site. Antibiotic prophylaxis strategies. Some adopt antibiotic prophylaxis, some do not. Again, it has been debated for decades, but no consensus. But the prime importance is microenvironment of the surgical site is to be optimized. No compromise on that. And before a surgery, enhance the host by enhancing his or her physiology, that is his defenses. Use asepsis, because patient-related procedures like hair removal techniques can cause infections. Pre-operative infections may be there, take care of those. Surgical scrubs and skin preparation has to be on the scientific grounds, because if you scrub not so meticulously, you may give the trouble. Again, antibiotic prophylaxis open to you, and the hospital policy. Operating room characteristics, we have to maintain an optimal temperature, optimal environment in all respects. And that means we should have filtered air in the setting. So do check your filters if in place. Let's not go on to the antibiotic prophylaxis for surgicals. Let it be left to the choice of the surgeon, because in the paucity of time I may not be able to discuss it. But some do recommend before incision, 24 hours before incision, it can be given. It has to be stopped. So this was about the hospital-associated infections, some 5 or 6 points I have discussed. There are many more, but so far so good. Equally important is the waste management in a hospital setting. Waste is generated by any of these procedures like diagnosis, treatment, immunization, and research, etc. This being a research hospital also, a lot of waste is generated by that. And this waste is either a regulated medical waste, or it may be a chemotherapy waste, a solid waste, or a hazardous waste. But I will be dwelling mostly about the infectious waste. For management of this waste, every hospital has to have some policies, and I'm sure we do have policies in place. We have some standard operating procedures in this place. We have an infection control committee. We have treatment plans. We have sewage treatment plant as well. So it's better to follow the hospital policies and procedures. There's a very important quote in one of our earlier textbooks which we come across, that is by K. Park. It's the textbook of preventive and social medicine, and see how important this is. This book I have read in my times, and my research must also. So K. Park was very well aware of this hospital waste, and he wanted that the waste of these sick not contaminate the lives of the healthy. So this is the message which I want to reiterate. These are the things which all of us know. These are pasted on the roadsides, every nook, even on the hospital walls. Please go through these, read them, and follow them to the best of your capacity. I'm not going to elaborate on these. I'm showing you a picture. This is how we handle our waste, especially the most dangerous waste from our hospitals. In fact, it's not safe at all. We throw it everywhere. We let the non-professionals handle any of these things, and don't stop even the hospital waste being managed and handled by these people. And you can imagine what will happen. The person gets hit or pricked, and then he gets infected. He transmits it to the family then transmits it to the vicinity and the society, and you can know the catastrophe. Unsafe syringes are available for these. I can say these are the scavengers, because they take away these syringes which are intact. And who knows, after cleaning and repacking, they are sending it for the reuse. Ensure that you don't let them do that, and you can ensure it by making it into pieces or shredding it. And finally, this is at least safe, because you can't get a contaminated syringe back for the use. So do make them unusable. And we doctors, rather all of us in the hospital setting, do not dispose of the dressings in the patient's bin, because at times anybody handles that. Ask for disposal bags, or you can ensure that whoever handles it and throws it in the disposal bag. And ensure all plastic and gloves are cut into pieces. As I said, shredding is very important, and put into the bleach solution so that at least some of their infective capability is cut off. Ensure that used injections and needle cutters are used. We have to be very careful about disposal, especially the cultures which are a sea or an ocean of infection. So handle it carefully and dispose of equally carefully. All the stocks or whatever is there in the labs, which is a waste, is to be handled very carefully. Spills. We come across spills, not in the labs, not in the wards, but even in any area where we may handle any of these contaminated things or fluids or anything. So you have to take very meticulously, you have to get rid of these spills. Put on the gloves that time. So this is one point where you necessarily need to put on the gloves. Wipe it with from the cleanest to the dirtiest area, that is from outside to the inside. Use an appropriate cleaning agent for cleaning, and then follow some common sense procedures like don't pick sharps that casually, you may get hurt. This is the scene in most of the settings in our hospital or any hospital in our vicinity or wherever I have come across. Mostly this is the scene. Avoid it. It should not happen. This is again, why should it be there? You have some place for disposal. If it is overfilled, if it is filled, don't overfill. You must be coming across these signboards in this hospital, especially hospital administration has put these beautiful signboards everywhere. Follow them. These are the indications what is to be put in what place. So you have a red bag, you have a black bag or a yellow bag, or you have containers for disposal of the sharps and needles. Do that. One more important thing that we should consider, we take it very casually. Aprons, linen, or anything which we handle. Handle it carefully. Contaminated surface should be rolled inside. Keep dirty linen away from your body because you will contaminate your clothes. And don't shake them vigorously, rather don't shake them at all. Roll them with contaminated surface inside. Use appropriate receptacles for any disposal. Do not touch the inside of the disposal container. Anything that is reusable can be reused, but it is to be properly cleaned. Properly cleaning doesn't mean only cleaning and rinsing with water. You have to take care of the contact time with an antiseptic and then drying it properly. We have come across so many instances of oats being infected in this place, so please use them after a proper cleaning and disinfection procedure, and never use disposable equipments again, because you never know what has happened after the first use. For all these things we need a multimodal strategy, and these multimodal strategies are in place, need to be refurbished, and hopefully I am expecting that you will adhere to them. We have a change in system which is anticipated. We have to educate the people who are handling these hospital wastes or who are responsible for the hospital-acquired infections. We have to have a monitoring committee in place. Unfortunately, we have one in place in this place which has done quite a job, and hopefully it will be continued. Keep on reminding. This is not a talk today. People have to talk and listen and talk and listen again and again, because it's to be reminded to one and all. A safety culture is to be inculcated in our families. So, in the end, I will say, emphasis is on all of us, we doctors, we paramedics and stakeholders. It's a social responsibility. Care of waste is a social responsibility. Take it seriously and rub your hands. Rub your hands doesn't mean in desperation. Clean your hands, and that will save us a lot of trouble. Thank you very much.
Thank you, Dr.
It seems everybody has rubbed hands.
Dr. Kapoor, the prophylactic use of antibiotics. Would you have to say anything about the
being a microbiologist, I have developed a rationale and an SOP for any clinician to follow. And we are contributing by way of withholding some of the antibiotics which we test and we find sensitive, but we don't report. That is the biggest part of the rationale. Fortunately or unfortunately, the sad part of the thing is, people don't adhere to that rationale. It's very important. Because antibiotic resistance is because there is no proper use of antibiotics. What is proper use of antibiotics is after documentation of an antibiogram, prescribe the antibiotics. That doesn't mean you can wait, because you don't get time to wait for prescribing these antibiotics. Use them empirically till you get the actual report. That's the crux of the rationale.
But I think if we restrict it to antibiotic only, without taking cognizance of the actual use of the antibiotics, the pattern of the use, on the basis of the clinical pharmacological concepts, we are leading to the emergence, and the detecting emergence at the other hand will have no meaning as such, other than just emitting the purchase policy of the antibiotics. We have presented an antibiotic part once in our grant round. A very vibrant discussion here. I think before we prescribe some rationale and audit of the antibiotic use is necessary in the hospital. What do you have to say about that?
With due regards to Professor Ofai, sir, it is your domain. And I think guidance should come from clinical pharmacologists. We can simply help in that.
If you remember that in the previous years, we had a meeting in the education Sunday, and it was decided that clinical pharmacology will do the antibiotic order. But the order came in favor of the microbiology. Then we had this one-to-one discussion somehow. Anyway,
Like the side of it is, maybe we had lost favor that time, but we can gain it back.
I think we have to take some lead from that. What we discussed, want to. Okay, thank you very much. Any other questions? The topic was infection control and the biomedical waste management was a separate part of the title. Understanding that it's a component of the control itself. Was to highlight the waste management, or there was some secret message in it?
Second message was, as I showed a couple of photographs, overfilled waste bins. I did not point out what are the areas, but that is the message which I wanted to convey.
Thank you very much. Any other questions, please?
Topic of this session, that's the communication skills. I believe that is the third world countries, one of the very important topics, because most of the time medical curriculum doesn't deal with it. So we talk about the I was supposed to deliberate on it, but organizers is that he is out of town, and Dr. Asper Kutu is a consultant, surgical oncology, we talking about communication.
This is supposed to deliver on this. Basically presenting the communication skills on behalf of Dr. Ataji. When I was specifically asked by Dr. Ataji to make a presentation, I was reminded of my MCS days when we had a 3-monthly assessment there. And one of the assessments, we had a paper on which we had to basically a multiple choice question paper. I had to write about my colleagues and my paramedics. It was really the first exam of the year. But the age or email, how good he is, what's his rapport, what's his communication. And at the outset, I just tell you that I don't have any data, it's not my field, so I'm not going to present any data, any evidence here. It's mainly from the CRISP protocol which we follow in our department. I have taken these few things, but this is my own experience and my training in MCH. When I try to look at the communicability, there has to be a proper communication between the primary care physician, the patient and his bystanders, and the team with the primary care physician. Because if there's no trust between the boss and his team, or between the patient and the his primary care provider, things are not going to go well and we don't get a desired result. You will be very surprised to see that majority of litigations in Western world, and we have seen also here that if things are not communicated properly, things go wrong. We can see here it's not the lack of knowledge, the incorrect decision which lands us in trouble, but it is the poor communication, often a serial poor communication after poor communication after poor communication. Biggest thing we have seen in our practice that patient is doing well, he does not undergo any complication in discharge, obviously he is very happy. But I think one of the satisfying things for a doctor, especially for a surgeon, is that when a patient has got some complication or when he dies for post-op, his relatives or the patient as such does not have any grievance. He is quite happy the way things have gone. And the data is there to support that. The majority of cases of litigation are not basically due to any adverse effect or the negligence there, but it's due to the poor communication. That emphasizes how lucid we have to be in our talk, our talk with the patient when he visits us first time. The reasons for instigating litigation, as I mentioned, are the desire to correct apparent deficiencies of care, to find out what happened and why, to enforce accountability, to gain compensation for accrued and the future costs. And data suggests that 70% of litigation is due to poor communication. And it's a line mentioned in our protocol that over half of patients who commenced litigation claimed that they were so unimpressed by the doctor that they wanted to sue him or her before the alleged event occurred. So that emphasizes how the communication skills are important, especially in present-day world. We see in our day-to-day practice, in our OPD, patient comes to you with a diagnosed case of cancer, but he tells them that I have been referred from this hospital or that hospital by person X. He told me that you don't have anything, you just have infection. He is suffering from cancer. We can't hide facts from the cancer, but at the same time, as was nicely mentioned by HRs, we have to be empathetic to the patient, not sympathetic to the patient. We have to cater to his needs, his concerns. We can't put ourselves in his shoes. We can't be sympathetic because we are not suffering through the same ordeal. If we look at this, a very busy slide, but if we look at the communication skills, unless and until we don't know the task, we can't develop a communication skill. So first thing what we ought to know is that what task we are, do we have to inform the patient, do we have to take the consent from the patient, have to tell the patient what disease is, what prognosis is. So unless and until we don't know the task, we cannot develop the corresponding skill for it. The purpose of communication, as highlighted here, is to elicit and provide information quickly and accurately, to be able to respond to psychological and emotional issues in colleagues, patients and relatives, and to be aware of the possibility of tensions or distress, building up within a team and to know how to respond to it. When you got wrong working hours, not 8 hours, 10 hours, 8 hours, 10 hours, 12 hours, especially when you're in a theatre or in a ward setting, you know that your resident is there for the last 24, not 24 plus 8, 32 hours. So you have to feel that he's getting tired. He may not acknowledge it, but you are the person who's saying that no, he's getting tired, my team is getting tired, so I have to take decisions and I have to communicate appropriately to them. Basic communication skills. When the patient comes to us, we should avoid focused questions, closed questions, yes or no answers. No. It has to be an open question. Okay, what do you have? How do you feel? What brought you here? Or like, what's your main problem? So this is an open question. We can't sort of make our questions focused or make them close with a yes or no answer. As a part of good communication skills, always a leading question has to be avoided, and always try to avoid multiple questions at a time. Do you have pain in limb, throat, where? Sometimes patient can say no to something, but you interpret that he's saying no to some other thing or all the things. If you don't know how to handle the issue, the best is just over it up. Suppose you can say that my problem is that I have only 5 minutes and I'm going for the theatre. What's your problem? Just tell me. Is it all right? Blocking. Blocking is a issue, is definitely one of the issues to talk on. Like as a surgeon, you have to be very crisp and clear with the patient that this is your surgery. You are suffering from, suppose patient comes to us, perhaps I will tell her that you are female, you are just 20 years, your prognosis is excellent, it's 95 over 30 years, 20 years, 30 years, so about 95 to 97%, but things may go wrong. I was astonished to meet Dr. Carol Bradford just a few months back, and she told me that whenever she does a thyroid, simple thyroid surgery, she takes consent. Suppose patient is supposed for lobectomy, she takes consent for total thyroidectomy, she takes consent for permanent retinal nerve damage, she takes consent for the temporary damage, for the hypocalcemia, and even death on table. Although we all know that recurrent palsy permanent 0%, temporary death in 10%. But in today's world, we are very lucid with the patient, tell her or him what's the course of events and how things will shape. So the concept of blocking, blocking on part of surgeon will be to hide facts. No, everything will go well. No, it can't go well. The data is supplemented. All the things, every time things don't go well, you have got complications and you have to make your patient aware of it. And I'm reminded of our incident quoted by one of our elders about Alamatusi. Alamatusi was a scientist. He told his king that I want to put an observatory. And king told him, why do you want to build an observatory? He told him, why it will help us in predicting floods and a lot of things. King says that, how will that help us? He said, I will tell you how it will help us. What they did that in that darbar of king, they made a hole in the ceiling and started they rolled down the vessels through that hole. When vessels started rolling down that hole, there was huge chaos there in the hall, except Alamatusi and king. He said, why? Because we knew that vessels are falling from there. So you anticipate for it. So similarly, your patient he has to anticipate that things may go wrong and to be better prepared to face those events. And blockage on part of the patient will be that he will simply deny it. That no, I don't have a cancer. No, it can't be. It can't be me. So it's the art. In fact, this was a more of artistic topic, the communicability. So it's an art how to really pacify your patient and how to communicate facts to him. At the same time, don't hide the truth. Mirroring, somebody referred to it, but the term mirroring was not used. That the mirroring is the tone, the body language. You have to basically mimic the tone and body language of the patient. If it's soft, you have to be soft. If he leans forward, you also lean forward. So he feels that no, you are caring for him, you are listening to him, you are not busy with something else mentally. So doing something opposite to patient or someone's anti-mirroring should be avoided as it can affect the communication adversely. This is one thing which probably I have to learn a lot, and all of us have to learn that we have to be assertive. Yes, we feel that this is the best thing to be done. I once again reminded of my mentor, Professor Monia in one of the debates we had with the Tata Memorial guys. It was about parodontectomy. He at onset said that my mother has told me one thing, don't argue with a lady. You will never win an argument with a lady. But then he told that once you are, you indulge whatever you want to do, go ahead and do it. Don't listen to her, but don't enter into an argument with her. So same is here. You have to be assertive. Do whatever you feel right. Do it. But you should not be incompetent, and if things are going wrong, you should not be aggressive to your staff, to your team. There are communications problems, especially when patient is ill, is frightened, the staff is so busy, patient is not able to concentrate, or is having severe pain or illness, and that can be an operational fatigue which all of us experience. Usually surgeons by 6, you start surgery at 9 o'clock, by 6 or 7 o'clock you are already that tired and you really do lose your cool. So that's where that operational fatigue comes in. And then that you are part of the communication skills with your staff nurse, with your theatre staff come to practice. Specific communication strategies, they really vary the scenario. It can be different for a critical care setting and for other settings. One of the important topics which has probably not been touched in detail today's event is breaking the bad news. Once again, you have to be trained in it. It's a pure art how to break the bad news. The patient comes to you with cancer. We start with, like, the patient comes to me, taking the same example of a thyroid cancer, thyroid cancer. I tell the patient, do you know about hypertension? He says, yes, I know about hypertension. Do you know about diabetes? I said, do they have a cure? He says, no, they don't have a cure. I said, then you should be happy about a disease which has a cure. You are having a cancer, no doubt. You have a cure. That's how things can go in a proper way. So you have to break bad news, but you have to learn the art of breaking the bad news. You cannot hide the fact that you don't have a cancer. No, he has a cancer. You have to tell him that you have got a cancer. Are you in a curative setting or a palliative setting? You have to be very honest and upfront about it. Like, once again, things which will help in this thing will be probably start with an open question. Don't beat about the bush and avoid saying that I'm sympathetic. Once again, it has been completely dealt with. We can't be sympathetic. We can just be empathetic. And we have to document this. Very, very important. We have to document our concerns. Like the patient, we have to tell them whether he or she falls in a curative setup or a palliative setup. Very clear and leads to communication. Medical mistakes do happen. They happen in each and every center. Nobody does them deliberately. But when a complication happens, that time there are two things now. If it's done with negligence, now you have to break the bad news. And second, you have to handle the feeling of guilt. Something has gone bad. It could have been avoided. Madison was not careful. I was not careful. This could have happened. Probably best thing there is to be apologetic. Tell the patient clearly, we have missed a thing, which happens. Please forgive us, but we want to help you. Be apologetic and go ahead with the proper treatment plan. Working colleagues, people normally are saying, it's where probably issues come. It's not that you are team, you are the boss, or you are the team leader and you have got issues with your team. But when you seek a referral from the department, it's not your parent department, it's a outside department, how to interact with them, the communication with them. They have got their own way of doing things and you have got your own way of doing things. You want to see them from your perspective, they are seeing the patient from their perspective. There you have to probably, here with Dr. Ijaz nicely emphasized, it comes the role of the interdepartmental meetings, frequent departmental meetings, just a phone call to a colleague that thinks that I have a patient who interacts with these problems, what do you think? So these things can help. Once again, these are the everyday communication skills we have to develop. Probably make a timetable when you are going to start your morning rounds, when your academics will be there, when you play communication with the patient. Probably keep that once you finish the ward rounds. Just take some time off to spend with the bystanders, the patient himself, and so that the communications are easy. Because what's happening that your patient is just in a dynamic state. Things are changing, events are happening, and you want to convey to him that what's happening on daily basis. At times you need to be quite, I have probably dealt with that, you need to be quite assertive on your patient's behalf. But you have to learn whenever not to be assertive. Your patient may sometimes, like you have a patient of cancer, he says, doctor please use the palliative setup, there's got a metastatic disease, bone mass, lung mass, like mass everywhere. He says, doctor please do something. There you have to probably be a bit more assertive that, look, I will do best for you, but you have to also believe that you won't be cured, you are not in a curative setting. Once again, these things do help communication, especially between the younger staff, resident to resident. Once they leave, please do write nicely whatever you have done, and there should be a clear oral as well as written communication between the staff. And in fact, in this instance, the experience of a good and experienced nurse was really very good. I thank my teachers as a my elders have always taught me to thank your teachers, but that's what I have.
Thank you, Dr. Azhar, for making it so sweet and brief. Just one question. You were trying to put emphasis on assertiveness, but as we are discussing assertiveness, probably that time it goes against the basic principles of surgical ethics, like you are not to intimidate a patient, you don't go for condensation, you don't go for manipulation. Assertiveness will get mixed with that once
Yeah,
you...
it's a very fine line. I agree with you. It's a very fine line. It's almost, if you have to ask me, probably you fear the Almighty Creator, and then probably best word to sum up to tell where we should be assertive, where we should not be assertive. Things have gone wrong, and one has to learn that whatever has to be done is for the betterment of the system. It has not to be against the person. It has to be for the betterment of the system.
Thank you. Thank you. Any questions from the audience?
Davish to present a memento to Professor Zuhud and Nazar. Formal announcement, lunch will be served here for the third session now. Now on to the concluding session. Being a doctor, we are always taught that we are here to serve the humanity. Keeping in view the well-informed patient as a consumer and their legal protection under civil and criminal law, especially in medical legal cases, our main objective should be to ensure safety and professional spirit by adhering to our scientific and document patient education resources. Identify legal aspects of proper documentation. Moreover, we also have to keep pace with advances in technology. As such, we need to know what innovations in technology are existing and emerging. Without undue waste of time, I would like to call on stage Professor Ghulam Nabi Yaddu, head of the unit in the Department of Gastroenterology, to come on stage, sir.
Bismillahirrahmanirrahim. At the outset, I must thank the organizers for making me sit here, and I would invite Dr. Farooq A. Jan, Joint Medical Student SKIMS, to speak on medical documentation, including medical legal aspects and our pitfalls.
I am here to present medical documentation, including medical legal aspects and our pitfalls here. This slide I have not presented here to just frighten you, but to make you aware that knowledge of proper documentation and medical legal aspects of healthcare is very important for all the clinicians. So what is documentation? Anything which a doctor or a nurse writes while treating a patient, it becomes a document, and it is considered as a valid proof of what has been done on the patient. What is the purpose of documentation? The documentation is really important to see that the care that you are providing, is it meeting the required standards? Was the care which was provided to the patient, was it appropriate care which was needed? Are we meeting the standards which have been laid for management of different diseases? And also, it is important for our continuity of care, your future follow-up of the patient, legal documentation purposes, and also for reimbursements. So in short, documentation is important for all of us. The patients, the doctors, the hospital, everybody, it is important that proper documentation is there. If proper documentation is there, we can defend ourselves in the court of law if a litigation arises. So what are the general principles of proper documentation? medical record should be complete and legible, which we are always emphasizing on our rounds, that kindly write legibly so that we can read what has been done on the patient. And documentation of every patient is important. Be it sick patient, a patient who is doing well, documentation is important for all of them. But if a patient is critically ill, you have to take extra precautions. And you have to write the date on which intervention was done or whatever examination you did on the patient, and you have to identify yourself that who did what. I will not be stressing more on medical documentation here because I know that most of our clinicians or doctors, they are being told by their HODs, and we also are emphasizing on documentation every now and then. So what is a medical legal case? A medical legal case is a case where a doctor, a treating doctor, suspects foul play. And resuscitation and stabilization of the patient is of paramount importance and will have priority. And medical legal formalities can be carried out later on. Medical legal report has to be prepared on a designated form which is available in your hospital. And all the medical reports, they have to be kept in safe custody, because this is what is going to save you if a case, if a litigation is there. This is one of the forms which we use here. I think most of the people must be using it for ordering investigations in medical legal cases. This is the medical legal register, which is maintained by medical legal our doctors who are working in emergency. They have to properly document that what the patient is having, what was wrong on the patient, and again you can see that we can just pinpoint that where the injury was, what sort of injury was there. And these pictures are very important once the case is in the court of law. Another aspect is disposal of dead bodies in medical legal cases. If a case is a medical legal case, we have to hand over the dead body to the attending police. Police is the attendant for us in this case. And we have to just note down whom we have handed over the body. This has to be kept in our record. And all cases which are brought dead to our hospital, they have to be labeled as medical legal, and we have to obtain the details of the patient who was brought dead from the person who was accompanying. This is the release form which we have, the dead body, release of dead body. You have to take the signature that who was the police person who took this dead body in medical legal cases. Here it's one of the pitfalls, we are not doing it in our hospital. We have to be a bit prompt here in these situations. Then the medical certificates which we issue. A doctor has to keep a copy of the medical certificate with himself which he is issuing. But as we are working in the hospital over here, you have to make medical certificates in duplicate. One, you should hand out, basically both the copies should go to medical record department, and they will give the certificate to the patient, and they will retain this one certificate with themselves. Because what will happen if the patient, if any agency wants to authenticate the genuinity of this certificate, they are going to approach administration, and administration will approach medical record, has this certificate been issued through our hospital? And if only the certificate is registered with us, then only we will say yes, this certificate is genuine certificate. So we request all the doctors that whenever certificate is issued, issue it through the medical record department. And then you have to take proper signature of the patient when you are issuing the medical certificate. You may not put the photograph, but the signature of the patient has to be taken in the certificate, where you have to write that it is the specimen signature of the patient. And again, these certificates which you are issuing, they have to be kept in medical record department, and you can give, in our hospital at SKIMS, we have a designated certificate which is made by medical record department, and all certificates have to be given in that pro forma only. So another aspect is consent of the patient, especially a written consent when you are doing a procedure on the patient. You have to make it informed consent. Informed consent means that you have to tell the patient that what you are going to do on the patient, what are the alternatives available, what benefits and disadvantages each approach has, and then only you have to make him understand that he understood that what is to be done on him, and this is called as informed consent. If a patient is unconscious and has nobody accompanying, treatment has to be carried out. You don't have to wait for consent. Again, here we see that people come to control room that this patient has this body, this patient has nobody accompanying, and he needs surgery. We have made a system over here that will take signature one from casualty, doctor in casualty, another signature from doctor in control room, but that is not needed. If you document that patient is unconscious and the treatment is necessary, you can go ahead with the treatment. These are the forms which are available: informed consent form for any procedure and consent form for surgery. These have to be properly filled, because these are going to, because tomorrow patient will not say that I was not informed that what I am going to do on what doctor is going to do on the patient. If a doctor thinks that he may need to extend the surgery, he should inform the doctor, that he should inform the patient that yes, you have this disease and maybe I am going to go for this surgery, but maybe I need to do something more. For example, if you are going to go for laparoscopy, maybe you have to open the patient. It has to be told to the patient. Then consent of one spouse is not essential for carrying out operation or treatment on the other spouse. Only exceptions are if the surgery is going to lead to sterility or is the case of in vitro fertilization. Then discontinuing treatment. If an unconscious patient necessarily needs treatment and the attendants say that we are going to take this patient home, we have to label this case as medical legal, inform the police and then discontinue treatment. Because you never know what are their intentions, even if they are legal here. Normally, what I told you, that examination of a patient has to be carried out after taking proper consent. But if the police or law investigating agencies want you to examine a patient who has done some crime, you can use reasonable force in examining that patient. But the request has to come from an officer not below the rank of sub-inspector. And then therapeutic privilege means that you have to inform the patient that what he is having, what Dr. Azhar was just now saying, that you have to break bad news to the patient, and then you have to develop the skills of breaking a bad news. But you can withhold the bad news if you think that the patient is a case of psychosis and it can harm his stability. This is what I told you, that patient, whatever happens then between patient and doctor, it is confidential. It has not to be disclosed. But if law enforcing agencies want you to have some information about a patient, you have to disclose this information if the court of law wants you to disclose it. Then during treatment of the patient, you have to follow the ethics which we have been taught during our graduation. You have to follow all those medical ethics. And simultaneously, you have also to adhere to the basic and requisite treatment guidelines which a patient mandates as per the documentation you have carried out. What I told you, that patient-doctor relationship is confidential and you don't have to divulge it unless wanted by law, court of law. Never tamper with the medical record. So if a mistake has happened while documenting, never use whitener, never scratch out so that it is not legible. Just draw a line, just cut it by a line, initial above the mistake, and your job is done. Record all the progress of the patient. What happens? A patient, we were treating a patient, everything is going nicely, patient is doing well, your records are showing that patient is doing well, vitals are maintained, suddenly there's a death note. So usually what happens there is that when the patient turns bad, for example, he has a cardiac arrest, he has a seizure, you concentrate on what has to be done.
on the patient. You give the medical treatment to the patient, but you forget to document it. What you document is death note. So you have to write that patient went through this phase, and then you have to write that something went bad. And kindly don't blame yourself. I have seen number of notes. Control room was asked to give BP apparatus was not given. This doctor was asked to see the patient, doctor did not turn up. So kindly don't blame your colleagues. Try to. It can be done separately, but not on the patient record. Court believes what is documented. What is not documented is not done. Recording of dying declaration in emergency. Normally, dying declaration is to be recorded by the area magistrate. But if no area magistrate is available and the patient wants dying declaration to be recorded, it has to be recorded by the treating doctor in presence of 2 witnesses. He has to make dying declaration in duplicate. One is it is to be sealed and sent to the medical superintendent, who will send it to the area magistrate, and one is to be fixed with the medical legal register. Another aspect is preservation of trace evidences. All evidence collected has to be saved. It has to be preserved. You have to take 2 samples, maybe gastric lavage, seminal stains, whatever, blood, urine. 2 samples have to be taken. One has to be sent to the police, and other has to be sent to your own lab. These are the different these evidences which you maybe have to take, as blood, clothes, vaginal swabs, seminal stains. We have a medical legal cell functioning in our department under Department of Hospital Administration, and you have to use these containers for various evidences you have to preserve. Again, this is the vial which we use here. These tubes which have to be used while if you suspect alcohol consumption, you can just preserve the samples in these tubes. This is how you have to preserve the sample. It is to be done by the treating doctor. It has to be properly sealed. The signature of the doctor is over here. It should have been here, so that half of the signature is on one side of the flap and other half is on the other side of the flap. You have to document the date. You have to put the number date in which you are dispatching it to the relevant laboratory. This is the form, the request which we send to the forensic lab. It has to be documented that who is the police person who is taking this sample to the forensic lab. They don't accept any sample unless it is sent through assistant sub-inspector of the police, and it has to be properly signed by the doctor who is taking the sample, who is taking the evidence. This is the injury report which we issue from our emergencies, signed by the doctor and countersigned by the HOD. Another important issue in medical legal cases is medical negligence. So what is the medical negligence? Medical negligence is a mistake by a medical practitioner which no reasonably competent and careful practitioner would have committed. Everybody of us is knowledgeable, we know what to do. Only thing what you have to do is that be a bit cautious, be a bit careful, and try to deliver what you know. See, the litigations are rising. You must be knowing that there are a number of doctors working at SKIMS against whom there are litigations. One is a case where the chest tube was withdrawn. This is a case where the oxygen cylinder bursted and the attendant lost his eye. And the case was lodged against this doctor, which I don't want to disclose who is the person. Still the case is going on. So be careful. The doctor should not have himself opened the cylinder in this case. He should have done it through a nursing aid with using a proper key, so that the pressure would not have gone high and the flow meter would not have ballisted and the patient attendant would not have injured his eye. Guideline for action in case a patient is found missing from the hospital. If a doctor sees that a patient is missing from the hospital, ask your nurse, your nursing aide to locate the patient. If the patient is not located within 10 to 15 minutes, report to the administration that this patient is not traceable. This patient has to be discharged in absentia, and if the patient reports again, the doctor should admit this patient against a fresh MRD number, because you don't know where this patient was, what he did, what happened with this patient during this time. Another concept is indemnity insurance. The concept is growing on. More and more doctors are opting for this. So recently, one of the doctors approached administration that we should have an indemnity insurance for ourselves. Indemnity insurance will give us financial protection, but it will not give us physical protection. That is, it cannot save us from going behind bars. There are a number of legislations we have to adhere to, which have been, some of them have been discussed before me. I will not go through them, I will just name them. Biomedical Waste Management Handling Rules, Transplantation of Human Organs Act, Consumer Protection Act, Drugs and Cosmetics Act, Prenatal Diagnostics Act, MTP Act, Right to Information Act. All these acts have to be adhered to, and we all have to have knowledge of these acts. Then human experimentation. Whenever you go for your research, there is an ethical committee existing in our hospital. Go through that ethical committee, have informed consent, take consent from the ethics committee for any research you go, especially if you are going for human experimentations. As I said, that we have medical legal cell functioning in hospitals since last 3 to 4 years, and we carried out a study between 2014 and 2015 to study our bottlenecks in our medical legal case management. I'll just quickly go through 1 or 2 slides. You can see that case files properly marks for 64.7%. This is the study which was done in emergency medicine department. Cases entered in medical legal register 75%, police intimation done on reception of 65%. Here you see that 14.7%, police informed on discharge. We don't inform the police on discharge of medical legal cases. We hand over the patients to the attendants or the dead body to the attendant. Here we have to take care that we inform the police that we are discharging this patient. Then another problem which medical legal register this cell was facing was that we were sending cases to forensic lab and we were not getting reports. You can see during this period 0% reports were received. Then we discussed the issue with the director of forensic lab. We told him, what is the issue that you are not sending us evidence? He told us that the issue is that you need to have a sub-inspector in your place, assistant sub-inspector, and all samples have to be sent through him. Then I personally discussed the case that with Director General of Police that time, IGP and DIG, and then after a lot of persuasion, they posted an assistant sub-inspector of police in our hospital, who is present in our hospital, and now we are sending all evidence through him, and we are getting reports now from that lab. It was one of the lacunae, and we have addressed this. Another lacunae is that we are not doing autopsy in our hospitals, and we have to do autopsy. 25% of the dead bodies we have to carry out autopsy, especially in medical legal cases. And this thing has some administrative issues involved in it, and we will be trying to address them. Then we try to study the knowledge among the doctors about medical legal cases. We saw that there was a significant difference between the knowledge among the male and the female residents. Then again, significant difference between the knowledge between junior residents, postgraduates and senior residents. Then the knowledge improved significantly as the experience of the doctors improved. There are a number of other findings in the study, but I will not be able to go through all of them. To conclude, I will say that what I said in my presentation, that knowledge of documentation and proper medical legal case handling is important for doctors, patients and the hospital, and need to be adhered to strictly. Thank you very much.
Go to section discussion. If there are any comments and questions, please.
This session is Professor Shalik Usudi. I don't think he needs any introduction. He is known to everybody, very dynamic endocrinologist and does wonderful research and grading to the people, particularly postgraduates. And today,
thank you everybody for being here. The topic given to me is research methodology. Certainly, it is not ideal time to discuss this topic, which is a very brainstorming topic, and when you are at the end of the session, you are running late, you are exhausted, you are hungry, and you are also looking at the watches because your buses might soon be leaving. But to complete the quorum, I will do this and I will try to be within the time I have been allotted. So the lecture outline I had planned it that I would first talk about the background, then research process, then research design continuum, then I will talk something about experimental designs, then sampling methods, scientific reasoning, research strategies, and then at the end I would give a brief how to make a research proposal and a research report. But I will have to now cut down many of the slides, so I will straightway go to the bull, catch it by the horns. So what is research? I was one day asked by a non-doctor colleague of mine, he's sitting here, Dr. Tushna Kara research. He was basically concerned that I was denied a thing which he thought was denied because I don't do research. I didn't tell him that time, but I tell, yes, I do research. So do you. So does everybody. Everybody. Human being does research. When we go to market to buy a fruit or a vegetable, and we check the prices, the quality, the different vendors, and then buy it, we are doing research. When I go to the website and check the prices of the, say, airline tickets, I am doing research. Yes, we don't report it, we don't publish it, which is an essential part of the research. And there are many definitions of research. The common anecdotal one is, research is what I am doing when I don't know what I am doing. And another one is that research is to steal ideas from many. This is compared to plagiarism, which is when you steal ideas from one person. But on a serious note, there are also several definitions. The best one and the simplest one is by Tuckman, that research is a systemic means of problem solving and has 5 characteristics. Systematic, logical, which can be inductive or deductive, empirical, evidence-based, reductive, and replicable. So why do we do research? Of course, most of the people here whom I think are residents or postgraduates or PhDs who are doing research in the form of a thesis, basically they want to get a degree, and for that a thesis or dissertation is important, so you do it. Some people do it for respectability, some want to face a challenge, some want to help the society. But the fact is, which we don't state but we know it, we just do research to improve our CV. Because for CV we need a publication, and for publication we need to do research. Now what is the research process like? It starts with a good review of the literature. And we try to see a question, a good research question which interests us. Formulate the question, select the appropriate research design, which I will come to later, then collect the relevant data, then interpret the findings and publish these findings, then go to the literature, and this circle again starts, whether you do it or somebody else does it. I don't have time to explain what is reductionism, but a few things come there, like what is basic research and what is applied research. Basic is basically, which we mostly do in the labs, is theoretical, is more invasive, it is tightly controlled, lacks external validity, though it has good internal validity, it focuses on mechanism, and it is more reductionist. Whereas applied research gives us quick answers, it is less invasive, it is field-based, loosely controlled, externally valid, validity is more external validity, focus on the effect, and it is less reductionist. For example, just to make my case clear, a question of applied research should be, does caffeine ingestion improve athletic performance? So this is an applied research question, whereas a basic research question would be, you can take this question differently. I will think whether, how will this affect the muscle contraction? And if I prove muscle contraction is improved, yes, caffeine. or I may think it may improve the metabolism, it may make availability of the nutrients, the glucose or lipids for energy, which give ultimately ATP, so it may improve performance that way. Or I may think it may improve the nervous system, stimulate nervous system, which may improve the performance. So it depends on what way the basic researcher thinks. He will do the basic research. For example, he may do that. He will think, does caffeine ingestion improve calcium binding with troponin? So he can do in the lab. He can check it. Would this facilitate actin myosin coupling? Would this aid contraction? He can check same way for the metabolism. He can same way check the nervous system. So this is how we break down and apply research into basic research. Sometimes we start with the basic research and then you will apply research. Now we come to research designs or research design continuum. Broadly, we have three types of research designs: analytical research, descriptive research, and experimental research. Analytical can be used. You can just read some good review, which often come in good journals. The better will be meta-analysis, which is basically a review of many papers on the same topic. It can be a descriptive, analytical research can be philosophical, historical, whereas descriptive research, which most of people do here, is either a case study. We report an interesting case and we presume what happened there will be applicable always. Or we do a survey where we ask questions and make a generalization from the response we get. It may be a cross-sectional survey, it may be a longitudinal survey, or it may be a correlational survey. The most important is experimental design or experimental research, which can be pre-experimental, quasi-experimental, or truly experimental. And we can also have specific statistical models. Analytical research, I don't have time to discuss that. Descriptive research, you all know, we do case studies, we do surveys. Correlation research, I want to talk because I find most of the PGs coming to me, sir, इसका वो correlation coefficient निकालना था. I have interest in statistics and I see when they get an R value, they become very happy because when you see a correlation coefficient, a Pearson one or any other one is 0.3 or more, we say a very good correlation. So by that we are basically observing two variables, say X and Y. If we find that X is increasing and Y is also increasing, or X is decreasing, Y is also decreasing, we believe that there is a correlation. Or it may happen that there may be a third variable, which is Z, and Z is basically doing both, increasing X and Y. But correlation does not mean causality. To explain my point, this is spurious correlation. I think I took it from web. There's a website like that which gives you these correlations. So what we are finding here is the cheese consumption, which is given by the red line, and then we have the number of people who died by becoming entangled with the bed sheets. We find a very strong R correlation, but we know it's a spurious correlation. So another interesting one, the blue line in the top graph shows the age of the Miss America from 1999 to 2009. Whereas the red shows the murders by steam, hot vapors and hot objects. We find a very, very strong correlation, 0.87. But please don't report such correlations. Of course, when you are in a thesis, you don't know what is happening to variables. Please be aware that there may be a spurious correlation, and in no case it says causality. Now we come to experimental research, which involves the direct assessment of how one variable influences the other. There we use some definitions like we have independent variable, which means this is the cause. This variable, when it changes, the other variable also changes. So this is an independent variable. It can be manipulated or allowed to vary. It is also known as predictor variable. And then we have dependent variable. This variable is the effect. So this should only vary in response to the independent variable. When independent variable change, this also should change. And this is also known as criterion variable. There was predictor, this is criterion. Then there is a law of single variable. that there will be always uncontrollable influences, and there will be extraneous variable which must be controlled to isolate the effect of this independent variable on dependent variable. In that we have a very commonly used term, confounding variables. What is a confounding variable? For example, somebody was seeing how many people were present during each lecture, and he finds the maximum number was during the research methodology. So that means doctors are interested in, or people are interested in this topic. But there is a confounding variable that this talk is happening at the end, when the lunch is to be served. So there is a confounding variable which may make the people be there, or can be reversed also. So experimental design, I told you there can be pre-experimental, post-experimental, and truly experimental. So again, I will come with the example. In pre-experimental, this is just a one-shot study. We take people, give them as a supplement, see their muscle mass. Muscle mass is good, we say protein supplement is doing it. But problem is here we are not controlling for anything, and we are not. We don't have any pre-test there. Now we can do a pre-test. We observe the person's muscle mass, give the protein supplement, then do observe again, and we find the muscle mass has increased. So we are right in believing that this supplement works in building muscle mass. But again, we don't know this factor, this person or this variable would have other variables that would influence. The person was basically an athlete. The person was basically going to gym otherwise also. The person was having other things. Or the reverse could be he has some disease which prevented from getting this. So here we don't have any control over the allotment. Every person are giving. And the example of pre-experimental will be that if we try to see muscle mass in vegetarians and non-vegetarians, we find vegetarians have more muscle mass than non-vegetarians. But then we don't know the people who are vegetarians might have some other reason to become vegetarian, which might have given them a favorable or unfavorable effect. Then we have quasi-experimental, where we have a series of observations in time before giving an intervention and after intervention. So we find that after intervention observation shows that there has been an effect. So this is better than the pre-experimental, but again the problem is here we are not controlling, here we are not randomizing. We are giving the person irrespective of his other variables. So a true experimental would be that while we do a randomized comparison, we take a group who have all the parameters similar, and then we divide them by a process of randomization in two groups. One we give treatment, the other we give placebo, and then we observe after the treatment. If we find that after treatment the muscle mass has improved in the treatment group, not the placebo, and at the end the treated person has better muscle mass, we conclude definitely this is better. Of course, people do pre-test. We see there in pre-test they should be comparable. Post-test there should be a difference. Then only we can say the treatment worked. Another way, which is the best way, but we often don't do it, is a Solomon 4-group design, which I don't want to discuss. But the only thing, it is like a true experimental where we have two extra controls, where they are not being given treatment, and we see with time what happens. Because when you do a pre-test, it has been found that this may affect the results. Like for example, we take a group of students and we divide them in two groups. One group randomly we divide them in two groups, and one group we give a kind of course, how to take hospital, like we were taught how to do this before this documentation. The other group is not given. But it has been found with time, the other group may learn from the people who are doing it. So they may also be doing the same thing, so your results may not be necessarily applicable. So another concept in this is sampling. Sampling, I think we all have heard the sampling. For example, we have a bag of Smarties, Cadbury Gyms, and I want to know how many are red colored. So the best would be I just go and count all of them, but if there are too many, it will be a cumbersome thing and I will spoil all the gyms. So what I do, I take a sample. And in that sample, it may be a small number, maybe 30, 40. I see how many are of red color, and I presume the same percentage will be in the whole bag. And I can say how many red smarties there are. But problem here is that this sampling has to be systematic, has to be done randomly. Problem is, if I, for example, take first three and all of them are red, and I don't know rest what are they, but I presume all of them will be red. But that is not true. So people have tried to overcome it by making different sampling designs. Like one is simple random sampling, where we use a computer for generating random numbers, like we give all the number and see what numbers we pick. Or previously we used to put the numbers in the envelope, and the envelope we could then see which one person picks, so-called lottery method. Other method is stage method. You must have heard multi-stage sampling, where we choose a school or a group, well, like a school, and then see a class randomly. And there is cluster sampling, and stratified sampling, systematic sampling, and the last one is opportunity sampling, which many times we do but which I never do. It's a convenient. I want to see say school children, their say thyroid size. It's very convenient to me. There's a school nearby, I go and see the thyroid size. But there's an inherent problem. This school may be people who are high in socioeconomic status, low in socioeconomic status. They may have a different diet. So this will not be a true sample. I don't have time to discuss these methods in detail. Then comes the reasoning. We have a general theory and then a specific observation. We may start with the general theory and go to observation, so-called deductive reasoning, which was given by Aristotle. It is like Socrates, we say all men are mortal, and Socrates is a man. So that means Socrates is also mortal. So we deduce from a general theory, a specific observation, that Socrates is man. The problem with this is, it is better. It is a way of quantitative research, but we have to have an observation should correlate with this. For example, in Greek mythology, they would say women have less teeth than men. They have only 28 teeth. So this was a theory by intuition. So as the deductive reasoning would have been, the Aristotle or Socrates could have counted the number of teeth in his wife. And we have found, no, that's not true, but he didn't do that. So deductive reasoning, you have to have this general theory proved by specific observation. The reverse is inductive reasoning, which was given by Bacon. Baconian reasoning, here we start a specific observation, then we have a theory on that basis. As I was giving an example of gyms, if I take 3 gyms, first is black, second is black, third is black. I may presume all the gyms or all the smarties will be black. But like in surveys we do, we go to a small, population. I see many the nursing students, MSc, they do the surveys. And they select a small sample, and then they take their answers, and they presume these answers will be applicable to the whole population. This is inductive reasoning, that is actually qualitative research, but it has its own limitations. People ask what is qualitative and quantitative research. I don't have time to explain that, so I'll move on. Now, how to do research? Because this is, people say, hey, research, research. They say jealous woman does better research. You know why? Because she has the will. So to do research, you have to have that will. You have to have that curiosity. Unless you have that curiosity, that why this, that research you cannot do. The most difficult question people say is the question which starts with why. So unless and until you ask your mind, yourself, why, that you cannot do research. So if you have that intuition, then the research process, we have 3 steps. Phase 1 is first step, essential. Then phase 2 is data collection, and phase 3 is analysis and interpretation. I can't discuss them in detail, but most important is a research question, to make a research question which has to be feasible, question should be clear, question should be significant, and then we have to decide a research method and we have to make a research proposal. Because money makes a mere go, money also makes the research go, and for money you have to go for a grant, and for a grant they will ask you a research proposal. So you have to learn, you have to know how to make a research proposal. Research proposal has, as you do in a thesis, it has an objective, it has a justification, it has an introduction, it has a background which is basically a review of the literature, then you discuss methodology, then time frame and the work schedule. You can't do the research sign and die, and facilities needed or which are available and what are required, and most important budget and the justification for the budget. Objective is the most important part. Once you made a research question, so you have the objective. It is better to have one objective clear than having many objectives where you are not clear. And your sample size, your methodology, everything depends on the objective. So introduction is basically you try to say the problem you are trying to study. I find many times once I review the papers or the thesis, the people talk in introduction everything what is in the literature. You have to talk only the thing you are going to do. The review of literature should be good. It is unethical to start a research without a good research, because without a review. I find many of the residents, they straight away started and then they wanted to do the review of literature at the time of writing thesis. They find this thing has been already done. It has been already solved. So, and a bigger study, a better study has been already done on this topic, and this is all waste of time, which is unethical. In literature, you start with who, what, where, and when, and why. I will leave my email number. If somebody wants to ask me in detail, I will tell you. Methodology, first and foremost, is study design. Whether it is a descriptive study or I am going to have a descriptive strategy, correlational study, or experimental strategy. Most of the PGs I found here have a descriptive strategy. Some have a correlational. Very few have experimental. Then we have to see the population, we have to see the sample size. Again, if your sample size is not sufficient for that objective to be studied, it is unethical. Because if the sample size is less, the power goes down. And the power of a study is the ability to detect a difference, the ability to diagnose a thing when it is there. So if your sample size is less, the treatment might be effective, but because of small sample size, you don't get significant results. And so you are wasting your resource, your time, your money, and everything. So this is unethical, because I am in the ethics committee, and people ask me, hey, what the ethics committee has to do with the sample size. Sample size is very important, because unless you have good power, you are not going to get result. How so good your research question may be, how so good your methodology may be. Then you have to write the instrumentation, procedures you are going to do, time frame, as I told you, because ethics committee will ask you for that. The phase D is collecting data, that is the easier one, but then many people take data as it is. It is very important to be objective, it is very important to be truthful. It is very important to recognize that there may be a gem of a data which may think you think this is absurd, it is impossible. I might be scolded, I might be challenged that you have not answered correctly, and people try to manipulate the data, they think this is not possible. So because most of the studies come when the data is good, when the data is truthful. And then you have to know how to clean data and then obviously analyze. Reporting has become a bit simple with internet, you know. You type any topic, everything is done there, right? So writing up authors after the research is done, not everything that is done is reported, and you have to leave some step out that we all know. But you should know the research report summarizes activities in such a way that they are clear to the reader, and so that the reader could repeat the research. If the research is not replicable, it is of no use, because nobody will believe you unless it is done by many other researchers and they also come to the same conclusion. So just mugging up the results or mugging up the conclusion does not help. So many millions of things are done every year, but many of them don't see the light of the day. The research report how to write a research report is a topic in itself. This is one I found that in this you find the red is the research of any real value. Rest is all material from outdated books, material from questionable websites, Wikipedia information, abstracts, other things. So this is actually your mark. So try to concentrate on this one and try to see if you can improve it. So I think you know it. The people who are going to submit their cases, they should ultimately research a report like this: statement of the problem, review of literature, statement of hypothesis or research objectives, description of research design, selection, operationalization of variables, description of sample selection procedure, description of how data was collected, data presented and summarized in words, conclusion, limitation and implication, bibliography or references you have cited, and lost appendices where you can quote the tables. Many universities ask you to put the whole master chart there, or you have to keep that ready. At the end, I would like to thank my mentor, Dr. Alan Schuldiner, who is at University of Maryland, School of Medicine, Baltimore. It was because of him I was inducted in as a visiting faculty in University of Maryland, and I had an opportunity to attend many workshops on research methodology. And if I can talk, I could talk today, it is because of him. He is a tremendous researcher. He has more than 400 publications on the PubMed, and a dozen publications in Nature, a dozen publications in NEJM. I thank him, and I thank you for being here. I know there is not time for questions, but I am leaving my email here and also my Twitter account. The present president of USA believes in communicating only through Twitter, so I am also now started using. So it's an old account, but you can add another now. Thank you very much.
Thank you, Dr. Sharik, for a very wonderful talk. I think we already closed the question session, but even then, if somebody has some interesting queries and they are just good, and Dr. Sharik, I'm sure will take those queries. You are all busy with eating. And, at the beginning, I thought that everybody was here to listen to your talk. I think they were more having lunch.
That is a compounding variable.
That should be right. So with this, we thank you very much for a wonderful talk. And if anybody has any queries, please just put them in the email. So you can always contact you. But my only suggestion to Dr. Sharik, I know most of our postgraduates, postdoc students, when they complete their data, and they are only looking for one person. Why is Dr. Sharik, sir, can you please talk to me? Please help them, but before you start helping them, tell them to read some medical stats. I think that should be at least, before they finish their something, at least they should know about whatever they have done. And I think we should all, guides, postdoctoral teachers, postgraduate teachers, we thank you very much for helping our students. Thank you very much. We have the last speaker. I think the last speaker in the session, Dr. Harun Rashid, and he'll be speaking on medical innovations. Dr. Harun, please.
Now the last one is the electronic underwear preventing bed sores. Having elderly grandparents that have died from complications due to bed sores is extremely unfortunate, as much of these issues could be prevented.